Well, hello and welcome everybody. I'm Dr. Simon Koss. I'm Microsoft's Chief Medical Officer, and it's my very great pleasure as co-chair of the Global Commission to End the Diagnostic Odyssey for Children with a Rare Disease to welcome you here. If you're joining us in person, thank you to all of the Global Commission members that I see here in the audience. If you're joining us from Rare Disease International, thank you for taking time out of your conference to be a part of this. If you're joining us from Brussels, where we're live streaming and bringing them into our conversation for the launch over in Europe, or if you're joining us on the web, thank you and welcome. This is such a momentous day. We've been working for about 12 months now as the Global Commission, and we came together to say this is such a complex problem around the world. It is bigger than any one organisation can solve. Let's take off our corporate hats or our individual hats, and let's come together to think about how we might be able to reinvent the future of diagnosis of children with a rare disease. So we polled together a commission that was very varied in its membership. We had people from the life sciences industry, esteemed clinicians from the genetic space, patient advocacy folks, and technology to say, we each bring some expertise, but let's look at rare disease and how we handle it today with a critical view, and let's think about how we might be able to do that differently. For myself, as a clinician who moved into technology 17 years ago, to understand where the constraints and bottlenecks are today for children with a rare disease, where it can take on average 5 years to get a diagnosis, where people have to go see 7 different providers and 40% of them are misdiagnosed. When you think collectively that some diseases are so rare that providers will never see them, but taken holistically, there's almost 350 million people living with rare disease around the world. They all have families and carers. This is a huge societal issue. So for me, having a look at how it is handled today, we're practicing a model of care that was established a century ago, and we really haven't tapped in to the modern technologies that can make a difference, from virtual care and telemedicine technologies through to digital record technologies and artificial intelligence. These are all potential solutions to some of our constraints that we have today. And it's been enormously gratifying to be a part of some of the trials, to see that the recommendations that we release today are not just paper-based recommendations. They are being lived in pilot programs around the world. So I hope you welcome us with the same enthusiasm that we have for the journey ahead. I'd like to introduce you to my co-chair, Jan Lecam from Odyssey. Thank you.
Thank you, Simon. Thank you for the slides. Sorry, I went the wrong way. Okay. Yeah, here we are. So good morning, everyone, and good afternoon in Brussels. The Global Commission to End this Odyssey of Children with Rare Diseases was initiated through 2017 and was launched last year on Rare Disease Day 2018. I'm proud that just a year later, on Rare Disease Day 2019, we're publishing this first report. The Global Commission goal is to enable children to have their diagnostic faster and accurate. Faster and accurate. We're waiting years to have diagnosis. 5 years on the average, even in regions like Europe. And accuracy is important because what we want to address is to reduce the number of undiagnosed children, but also of misdiagnosed children. Misdiagnosis is making us suffering and killing some of us. What is unique about this Global Commission is that it brings together the actors from different fields of expertise in health and beyond health, and that's really the value of this commission. And I'd like to thank our colleagues coming from the horizon of digital industry and technology. We wanted to explore the new potential of digital technology, of artificial intelligence, of web communication and social media, but in addition to the new sciences in genomics and how we can combine them and optimize with new approaches. But I would also insist that it goes together with innovation on the organization of healthcare. That goes together. Getting your diagnosed needs, then after that you need to have access to healthcare in order to have access to a care, not just to be stuck with your diagnosis. Our approach has been to focus and will continue to focus on actionable, so concrete steps in order to address barriers and challenges. The Commission is composed of experts, as you can see here on the slide, of patient advocates, and I'd like to thank them, and I'd like to say that here in New York today in the room, we have patient advocates from over 40 different countries and from all continents. They are from Botswana to Malaysia, from Brazil to Russia, from Croatia to Hong Kong. And thank you for being here for this event. Also in the group, we have leaders from the academic and scientific community. And these leaders are not top scientists. They are also leaders of networks, of learned society. So all the people in this commission were in a position to synthesize existing proposals and new knowledge, and that was the purpose of the group. They were able to anticipate and synthesize. The commission met 3 times in 1 year. It's a huge effort, and we've been performing a state-of-the-art of the technology, but also of the policy, and we collected inputs from the community, particularly on the solutions, from the patient community. We had also, needless to say, strong support from the extended team of the 3 organizations, Microsoft, Takeda, and New Orders. With this, and before handing over to our co-chair, Wolfram, from Takeda, I'd like to welcome online in Brussels, Manuel Mateo, who is representative of the European Commission, Digital Economy and Society. Thank you very much for being with us, and thank you to all panelists in Brussels for your participation. Wolfram.
Well, thank you very much for coming out today and joining us for this important event. As you know, I joined this group a little bit late, and I've always been involved since the beginning in the background. But this is a really unique opportunity, and I'm really humbled and privileged to work with all of you in this multidisciplinary fashion. And I think it's a really great opportunity, something really impactful, something we need to demonstrate for the future to our folks, our patients, everyone, that this is really changing the lives of our patients and making our life easier to communicate what we want to do, to diagnose patients. And I think this is a really unique opportunity for all of us. So I look forward to working with all of you in making this happen, and hopefully, it's going to be for many years to come. And we will hopefully be, in a position that everyone is envying us for what we do and learning from us and really implementing it in their daily lives. So today is really to celebrate the launch of the Global Commission 1-year report. And also I wanted to acknowledge another colleague of mine, Charles Platford, who is also at the Brussels event. He's the president of our European and Canadian business unit and also a member of the Takeda Executive Committee. So they're all in Brussels today. I hear they had a great meeting, and hopefully they can, see us and hear us at least, and everything is going well in Europe. As Jan mentioned, it was just 1 year ago that Takeda, and at this time it was Shire, and as you know, there's a lot happening in 1 year, together with Microsoft and Odyssey, announced a joint effort to address the issue of rare disease diagnostics in children. We gathered together a group of multidisciplinary experts and charged them with developing a much-needed roadmap in the field. And we asked them to do this in just a short 12 months. We believe that with this wide range of perspective, experiences, technology, expertise, and creativity, they could tackle one of the most heartbreaking challenges for rare disease patients, the diagnostic Odyssey. I am proud to announce that in the 1 year we have identified the major barriers to diagnosis and developed actionable recommendations. And I think that is really the key word, actionable, to overcome these barriers. Many of these recommendations address challenges that are distinctive to rare diseases and the technology is uniquely equipped to solve. We understood that the problem of diagnosis is multidimensional and one fix wasn't the answer. We instead organized the solution ideas into 3 distinct yet interwoven tracks: empowering patients and families, equipping frontline providers with tools for diagnosis and referral, and reimagining the genetic consultation. And for those of you who have looked through the report, it's a really nice summary of what we want to do, and it's outlined really perfectly, finding the right balance between science and something which is really understandable for a broader audience. So it's a really wonderful report. In order to create an enabling environment for these ideas, we identified several global policy recommendations that can be implemented at a local level, as Jan will point out later in more detail. And lastly, we wanted to test out some of these ideas. We have 3 active technology pilot programs that are designed to provide proof of concept and hopefully open doors for expansion and future collaborations. The goal of this report is to inspire concerted action and mobilize diverse actors within and outside of the health field to implement these solutions and improve the lives of millions of children with a rare disease. We hope that you can find something in this report which relates to you. Your action will help the field move closer to bettering the lives of children and their families. As champions for the millions of people living with a rare disease, this partnership is a step in Takeda's own journey towards transforming the lives of children and families, and we are proud to be a co-chair of the Global Commission. Before I turn it over to the panel, I would like to thank the members for their commitment and ideas, a cross-functional team of colleagues at Takeda, and the teams of Microsoft, Odyssey, and Raymond Martin for all their hard work. We already heard about Lynn and all her great contributions, but I want to thank her again in particular for all the great work she's done. She's worked for the last 2 years, and Lynn, special thank you. And you really, helped us to accomplish and be there today and really forge ahead with our global partnerships with diverse institutions and communities. So thank you, Lynn. And with that, I would like to hand over and welcome Mike Porras, who is a Global Commission member, also founder and CEO of the Mighty, and the board member of the DUPE 15Q. Just learned about the DUPE. And welcome to the team.
Thank you very much.
Thank you.
If I could get the clicker. Thank you. It's really a privilege to have been on this commission and be with you guys today. 10 years ago, we were on our own diagnostic Odyssey. My family, I've got 3 kids, and my oldest, we knew things weren't quite right with Annabelle and our daughter. And we got a phone call finally after 2.5 years of working through this, and the doctor on the phone said it's unlikely her mind is going to develop beyond that of a 5-year-old. And we got the diagnosis. I can tell you that day, that diagnosis felt devastating. But since, coming through all that day was actually liberating. Because once we had the diagnosis, we could find the community of people who were handling this. We could find the right doctors who knew more about this. We could mobilize as a community. And we're at the point now we're starting with clinical trials to actually develop treatments for people with this. So that point of diagnosis is so important. I know it has been for our family. It led us to the DUPE 15Q Alliance, ultimately creating a health community called the Mighty, which has millions of people trying to share their experiences with each other and hopefully get people to answers much faster. So there's another dad here that we're going to show a video of, Julian in Spain, who has a great story here. And you're going to first watch the video, and then you're going to hear a little bit more from one of his colleagues at Microsoft on what he's doing really to help provide a solution here. So let's click through.
Sergio, like other children with rare diseases, is a child who needs 24/7 support. When Sergio had the first seizure, we didn't know what happened. We ran into the emergency room. We ran into a lot of testings. We spent a lot of time, a lot of money visiting specialists, because when you don't know what's happened to you or your family, you try to find an answer. We spent 6 months until having the final diagnosis. The problem of this gap for the proper diagnosis is that we put Sergio in a bad treatment for rabbit. One day he had 20 seizures. We just stopped counting. Statistics say that the average patient with rare disease, they need to visit 7 specialists until having diagnosis, and the average time to diagnosis is 5 years. Diagnosis is important, not just for treatment, but also to find a group, find a community, a place where you can share your pain, share your problems, and get answers. The Global Commission is a global initiative. The ultimate goal is to create recommendations to try to improve the time to diagnosis. When the Commission was founded, I talked to the representatives on this global initiative and I asked them to be involved. I created this non-profit organization, Foundation 29, with the focus of using technology to improve the life of people with rare diseases. When you have a child with a rare disease, and because your life is going to change, the company you work with is very important. I feel lucky because I've been working in Microsoft for 20 years. Microsoft has a lot of flexibility to allow people with a particular problem to focus on what is important to them. We won't be able to find a treatment for Sergio, and we won't be able to make Sergio will be healthy and normal, but our energy and the work we are doing in our family is focused in order to avoid this situation for other children. If we are able to help other children and we are able to diagnose these children early and avoid the same situation that we have for Sergio, this will be great, because our life will have a purpose. We won't be able to make Sergio healthy, but Sergio, in some way, will be able to help so many people. This is our motivation.
So Dr. Clifford Goldsmith is going to come up and tell you a little bit more. You saw the beginning of Julian's story, and Dr. Goldsmith is going to help. Here's the clicker for you. Take you through more of what he and the work of his foundation is doing at Microsoft.
So thanks, Mike. It's great to be here with everybody and to be able to tell Julian and Sergio's story in a little more detail. It's one of the pilots that you saw mentioned, that Wolfram mentioned, the pilot number 1. And I'll say much more about it, but the work of this pilot that we've been supporting through the Global Commission and encouraging has been done in Spain at La Paz Hospital, and it's now being expanded beyond that. So I'm really repeating here what Jan said, but 5 years to diagnosis is far too long. And 40% misdiagnosis on the first diagnosis, and often more than that, is far too inaccurate. The goal of this pilot is targeted at the track 2 that you saw of the Global Commission, which is all about equipping frontline physicians to make diagnoses more accurately and faster. So I'm going to go now to the pilot itself, and I'm going to actually start the pilot up. This is running on a live site, so we're taking a real risk over here. And I'm going to do it now because it uses machine learning, and in doing machine learning, it's got an algorithm that it needs to run that can run for about 3.5 minutes. So I'm going to start the algorithm, I'm going to tell you what it's doing, and we're going to go back to it afterwards. As you heard from Julian in the video, he's a Microsoft employee. He started this foundation, has been supported by Microsoft in the work that he does, and has been doing and continues to do. And you'll also notice that this site is actually running in the Microsoft cloud, in the Azure cloud. I'm going to choose a new patient. And all I need to do for a new patient is put in one or two primary reasons why I'm concerned about this patient and why I went ahead and did next generation screening, sequencing on this patient. So it's just one or two. I don't have to do the complete diagnosis. So I'm going to start off by putting in febrile seizures, and I'm going to put in a second diagnosis of status, or a second presentation of status epilepticus. And then once I have the symptoms, I'm going to upload a processed file that's been processed from next generation sequencing and put into a variant format with all the mutations for this patient. And I'm going to open that file, and I'm going to let it run. So this is the process, the machine learning process running. If we could switch back to the slides while it's running. So today, the current process that we go through is far too single-threaded. What happens, I know as a physician in my training, that you work up your patient completely. You do a full symptoms, full signs, decide on your observations, and then ultimately work out as many of the issues that you can so that you've done all the work before you pass this over to some specialist or some diagnostician. And what happens in most of the processes is when all that data is passed over to the diagnostic team does their work, and what comes back, and this is typical not just of genomics, but it's typical of many tests in medicine, what comes back is a report, something like this, that I then have to work through to try and make sense in the case of my patient's clinical presentation. In a multi-threaded approach that you're seeing here, what you're seeing is something very different. Once I have one or two primary symptoms, you saw me enter them in, febrile seizures and status epilepticus, I then have the genome sequencing, and I put those two things together. What's happening now in the background, as this process is now running, it's taking both the phenotype and the genotype together and is going through those two together, going through the symptoms that you've given it, and extracting either off-target mutations, common mutations, unlikely to be clinically relevant mutations, and it's also prioritizing in the background all the clinical mutations that are in that sequencing, that sequence file that I put there, and making it relevant to that diagnosis. What it's going to do when it comes back to me in a moment, it's going to offer me further symptoms that I can then enter. So what this means, too, is that I don't have to know, as a primary care physician, every diagnosis and every presentation of every rare disease. I am going to the computer is going to come back based on the prioritization of the mutations and give me options to choose, and I will choose a few more symptoms that we know patients like Sergio with Dravet's disease have. Once that's done, the computer will then go off again, the program or the tool will go off again, and using this expanded list of about 10 to 15, which is what it requires typically, could give it more, typical symptoms or phenotypes or presentations, it will then use the genome again and come back with a list of prioritized recommendations for the diagnosis. What's important about this is not a diagnostic tool. We're not suggesting this can make the diagnosis. This is a clinical tool that supports clinicians in that process. And we'll come back to what that means to Sergio. So if you could go back to the pilot. So it's finished processing. And what it's got is it's telling me it's got two phenotype qualities already that I gave it. And it's telling me that's a pretty poor range of symptoms for using this tool effectively. I can then choose a few more symptoms. What's nice about this is it's doing two things. It's actually, one is I don't have to know all the symptoms, and I'm not even interested at this point in what the mutation was. I'm much more interested in what the symptoms are that I'm putting in. But it also gives me information, you can see, that I can learn from the system as well. So it's a tool that not just helps diagnosis or helps the clinical process for a primary care physician, but it also educates them. So I'm going to choose a few more conditions based on what I know that my patient has. And I'm going to go to the next mutation at this point. And I'm going to choose a few more from this screen over here. So I'm going to add a couple more over here. We know that the patient has an abnormal EEG, sorry. And I'm going to add a few others down here. And then I'm going to, for the sake of this demo, I've chosen about 11 symptoms, and I'm going to say I'm finished. And what it's done, the tool, has now gone out and prioritized, and I'm going to point this out to you on the screen here. You can see this over here. It's gone out, and with that set of symptoms and the mutations in that file, it's gone out and prioritizing. You can see it's still running. In 4 different ways, it's prioritizing the diagnoses. And you can see it's just completed, and Dravet's syndrome came to the top. It's classified the number of symptom matches. So there were 8 symptom matches in this case out of the 11 that matched Dravet's disease. There, you can see here that there's a phenotypic score for each of them under this category over here. And there's a genome matching score as well. And then ultimately, this tool, and these are publicly available tools that are being used in the background that are running as services in the cloud. This tool itself, the Health 29 tool, has given an overall rating. But what's really, really important about this at the moment is that while Dravet syndrome comes up with a 100% genome match, 3 other conditions come up with a 100% genome match. And they all need to be considered. And actually, you heard Julian say this to you in that video. They considered, I believe, one of these other diagnoses in the first case with Sergio. And what that means, unfortunately, is that 2 treatments can be diametrically opposed. And it actually exacerbated the epilepsy that Sergio had. So this kind of tool is important. This tool is far from complete. It made a lot of progress over the last year. But this is exactly the kinds of technology that the Global Commission is shining a really bright light on, and that we all need to shine a bright light on, in the hope that these kinds of tools can reach the point that they can become clinically relevant and useful to all of us. If we could switch back. I think the most important thing to remember is that technology is one thing, but behind every technology and every tool that we think about, there's a real patient like Sergio, there's a real family like Julian and his wife, and they are waiting desperately, like Mike said earlier, for a diagnosis. Thank you.
So, yeah, at this point, we want to welcome a few panelists. We're going to have a discussion. You guys can come on up. And I'll let them all introduce themselves for a minute or so, give you a little bit of their own background, the roles that they play. These are all commission members. And go ahead. And we'll have a discussion. I've got some prepared questions, but I hope it really turns into much more of a discussion. We'll also open it up to Q&A as we get through some of this. So, Marshall, why don't we start with you and come across?
My name is Marshall Summer. I kind of wear 2 hats. One, I run the Rare Disease Institute at Children's National Medical Center, and I have the privilege of being the board chairman for the National Organization for Rare Disorders.
Durham Walriger. I am the president and CEO of the Canadian Organization for Rare Disorders, and also really pleased to be the chair of the Council for Rare Disease International.
I'm Sarah Lee Hughes. I'm a haematologist, a blood doctor by training in London. I work at the Royal Free Hospital in the lysosomal storage disorders unit. So I look after a group of patients with rare genetic disorders, but I'm also involved in other rare disorders such as cancers and amyloid throughout the hospital.
And I'm afraid I didn't introduce myself at the beginning. Anyway. I'm Clifford Goldsmith. I'm a physician by training. I'm the National Director for Microsoft's provider industry in the U.S.
Yeah, I'm going to put this. Take this. You need it.
No, I just put it down.
Thank you.
So first question, Marshall, goes to you. One of my takeaways of being part of this commission was learning how few geneticists are actually out there. In many of the developing countries, you have 1 geneticist for every 3.5 or 4 million people. So how can we bring technology into these? We talked a lot about pre-appointment consultations, so the patients can be seen by geneticists faster, and that the families get a lot more information out of them during those consultations.
Mike, that's absolutely a great question and actually key to my field. It's not even can we or if we should, we have to at this point. The supply of geneticists who are the primary diagnosticians for a lot of the genetic rare disease versus the number of patients, and with all of this new information, all of the stuff coming from sequencing, all of the new clinic. I mean, when I started, you could diagnose 13 diseases. Now I can diagnose 8,000 to 10,000 diseases. And how do you keep up with that? Without a digital backbone, for a lot of that, you can't do it. The other thing we have to do is we have to start pushing things back to primary care. There's a real shift in medicine over the last 20 or 30 years as people sent patients more and more to specialists. Well, in a limited pool of specialists with a field as big and wide as rare disease, we actually have to have our primary care providers involved. So tools like 29, tools like digital opinions, basically where a physician can get a quick read from someone on this patient needs to get engaged, this patient doesn't need to get engaged. Because right now we're using kind of the, what I would say, the fruits of 1960s technology for this. So we've got to put these digital tools in place. We've got to push them back to the primary care providers. We need to make that bridge between them a lot shorter. We should be spending 30, 40% of our time directly communicating with those early providers rather than being at the end of this very long process where patients have gone through so many iterations. And we call it the lather, rinse, repeat cycle. You come in, somebody has a bright idea, they test it, if it's right or wrong. If it's wrong, you go back, you have another bright idea. We need to condense that process significantly. Using these digital tools is one of the best ways to do it because we literally don't have the personnel to do it.
Mm-hmm. And that actually flows to Derhan on looking at it from the parents or patient's perspective. Why is it important to empower these patients to work collaboratively, with their physicians, with the geneticists, and how can technology play a role in that as well?
Yeah, hugely important, Mike, and I think your story obviously illustrates some of the challenges that patients and parents have. And I think, and you're talking about living in a very developed country, and certainly for me as well in Canada, but we're also recognizing the fact that there are so many patients that live in countries that are much less resourced. I mean, obviously there's the internet that will help us, and I think that is sort of a major technology. And I love the fact that the first track that we recognize on there is empowering the patients and parents. Because what we know is that in many cases, you talk about that, 5 different misdiagnoses, or you talk about all the many years to a diagnosis. It's really patients and parents that continue to push that even get to a diagnosis. So, the whole notion is how do we put more tools into the hands of the patients? And there's some there now. I just will digress for a second. I really never talk about my own situation, but my daughter, when 34 years ago, presented with a whole bunch of unusual symptoms, both physical and cognitive. And they basically said to us, we have no idea after numerous tests. We'll wait. When she's about 2 years old, she'll either stabilize, she'll either get better, or she'll get worse. Oh, well, that was kind of interesting. So that was fine. And then we did actually end up with a diagnosis of actually thalassemia, about 2.5 years into it, but was unrelated to everything else that she had, right? So that's the other thing we learned, right? Just because you have one rare disease does not, can avoid other rare diseases. And then many years later, when we get the genome sequence and we're kind of like, oh, this is great, maybe we can find out, kind of what it is doing some kind of genetic testing. The challenge we learned at that time was that because she's adopted and we have no family members to match her against, we can't figure it out. Now I look at this and I say, yes. Not now that she's 34, she can decide whether she wants to get genome sequenced or not, so that's a whole different question. But I think it's being able to, as you say, to take this technology. And we're really excited by some of the tools that give patients, not just going on to Google, right, and figuring out, but very specific portals that allow you to do some of that demonstration that you had. How do we bring some of that to the patients at a level where they can go back to the doctor and say, here's what we're learning, here's what we're finding out, here's what we need you to help us do in terms of taking the next step. And I think that's the power of it, right? So that parents and patients can not only get and feel more empowered, but they actually can bring real knowledge to it. And that is what we see is actually available to probably everybody. And our goal is to actually, I sit also on the board of the Asia Pacific Alliance of Rare Disease Organizations, who have some of our members here, and they can talk to you about the exquisite challenges of living in countries where you don't get easy access, or people that live in rural areas, et cetera. So we're truly excited that, by being able to harness some of the things that we're talking about here, and certainly, the support networks, but also moving into technology. So this for us is a hugely, I think, big step. And as I said, I'm thrilled that what we're looking at as track 1 is how do we empower the parents and the patients so that we can get physicians like you to basically say, no, you're not crazy. We actually can help you.
And I encourage everyone to actually go and read the report. A lot of work went into it. You're hearing snippets of it up here, but I really encourage you to go to the website and read it. One of the things that struck me most is I work with Darhan closely around the patients and the just in terms of really empowering them and the families. And what struck me is we came up with the questions that they should be asking themselves. If you have a child who's just struggling in a lot of ways and you're not getting the right answers, and then there's questions trying to empower them to have conversations with doctors. And I think we need to get these questions spread out and for people to really acknowledge them and to empower the patients to ask them. Nobody told me that I should be asking these questions when we were going through it, and they probably would have gotten us a diagnosis much faster. So Darylyn, Darhan brought up genome sequencing, brought up technology. Can you discuss a little bit about how the Global Commission envisions using artificial intelligence, AI, as a tool for first-line providers to help shorten that time to diagnosis? We talked a little bit about it today. I want to take the conversation we had and share it with everyone this morning.
So I think this has massive power to go some way to overcoming that paradox of increasing information globally about all medical disorders, but yet with rare disorders, a few people disparately scattered around the world with their own little packages of information. And how do you bring that together so the patient in front of you has the benefit of all of that global shared learning? So let me try and illustrate that with a thought about a patient. So imagine little boy Joe out in rural England. His mum thinks he's not developing quite as quickly as other members of the family. Takes him to the family doctor, who of course says, well, go away for a few weeks, come back to me, it might all get better. In the meantime, things progress, things are noticed at school. The GP then, or his family doctor, says, okay, we'll refer you to the paediatrician at the local hospital, by which time he's had his first seizure. He goes into the local hospital. The paediatrician tries to pull the information together, but it doesn't quite fit with anything that they have seen or encountered. Things carry on getting a little bit worse, and they refer them to a specialist centre. Specialist centre says, this fits maybe a little bit with disorders that perhaps Dr. Hughes has seen, so they come to see me. Mum comes with a great stack of information that she's picked up at all the different consultations. But of course, it's her side of the information. I don't see the medical side from the hospitals. So the first thing I do is probably repeat most of the tests they've already had, because I don't really know what's happened, and I add on a few more. They all come back negative, but it gives me a little bit more information, and I refer on again to the next person who I think this maybe fits a little bit more of. In the meantime, Joe has some genetic information. It's sequenced, and we find that he's one of 6 children in the whole world who have a condition. So what do? Well, I write it up. I get my fellow to write a case report, and it goes into the literature so that somebody may be searching through the literature, through the publication system, finds some information on one case. So the power here is using artificial intelligence and machine learning to pull together all those 6 cases, all of that information into one repository, so that when Joe comes into that first paediatrician right back at home, they can put in the symptoms that you've seen, and those possible solutions will already come out. And Joe doesn't have to spend 3 years trekking through lots of different hospitals, having various different tests along the way. And I think that sort of artificial intelligence and learning, which will go on learning from Joe's case, putting his information into the cloud so that the power for the next patient will be even more, when that is coupled with all of the genetic information through whole genome sequencing, then we'll really be able to increase the power of making quick and also very accurate diagnoses.
That's great. Sure.
I want to add on that. I think you're spot on with what you're saying, both of you. And having a way where the patients and the families have in their possession their entire information packet, testing, diagnostics, symptoms. I know one of the things we spend a lot of our time on, even after all these other things have happened, is still pulling that together, and we still don't always get it all. So we don't go back down the same paths someone else has gone, so we don't repeat testing that doesn't need repeating. I mean, not only is it going to make us more effective, and it lowers the cost of the whole process too, which is one of the biggest barriers we have right now.
the other part of that is providing the legitimacy to what the patients and parents are bringing in. I just had another call just 2 weeks ago from a parent in Canada again. Her daughter was initially diagnosed with autism. And so she goes into a whole bunch of programs for autism, et cetera, et cetera. Turns out, of course, 2.5 years later, and the mother keeps coming back to say, that's not it. What you're recommending is not right. She's doing it again. Recommending is not right. And again, she lives in a major, in fact, she works in clinical trials research at a major hospital. And she says, at least because she's got connections, she knew how to break through. 2.5 years to get a diagnosis of Rett syndrome. When, in fact, if she had had that proper information accessible to her, she could have come in with the right information and, as you say, been able to get, because this is a known condition. And, I mean, it's a tragedy when you have a country, like ours, where you've got all that information and really good, centers that are actually specialists in that disease, and yet a parent cannot get a diagnosis for 2.5 years, and in the meantime have not only been misdiagnosed, but the child has lost a lot of options in terms of what could have been, sort of retaining some kinds of functionality, et cetera. Yeah.
And I would say another challenge we have is, once we finished up the Human Genome Project, we all thought, we got all the answers now. What we realized is we were just getting started. And there is so much background information to fill in. And, we talked about, like, the case report. Well, do you have the time to write the case report up and the information on the different patients? So one thing I'm become a real big component of are programs like the one NORD is running, where we're actually creating patient registries with longitudinal history data that belongs to the patient organizations themselves. They actually have the biggest interest in maintaining and seeing those move forward. And I think that's one of the ways we create a sustainable system, because if we do these little one-offs, and you were talking about that, if we have a packet here, a packet there, how do you ever connect those things? And really our patients are the strongest way to do that.
I notice I spend a lot of time in hospitals, and the hospitals have these big monolithic electronic health records and are very limiting and not interoperable in many ways, and that's a challenge. Yeah. But as I started learning more about the rare disease community, going to things like Global Genes and seeing the kinds of organizations that are involved, there is a different kind of medical record that people are at least presenting to the rare disease community, one that's based on the patient controlling that record or the organization controlling it. And I actually think there's a whole new technology that could ensure the security of that, and we haven't even thought about that, and that's blockchain. Yeah. I really think that it has value in securing the pathway of that record.
Yeah. And that will massively improve efficiencies and duplication, the time it's taken by people in other areas to actually look and say, okay, well, this is not only what the patient knows, this is what all the doctors all the way along the chain have said.
Clifford, the presentation you gave was awesome in terms of thinking about the impact on a family, right? In terms of being able to plug that data and get an answer, or at least guided toward an answer much faster. What would you say to a hospital system or clinic that is wary of implementing technology like that, or any kind of pilots that could help us get answers more quickly?
I actually would welcome that. I think that's the thing that moves us forward. I'll start off by saying I would have loved to demo to you what this tool that I showed looked like a year and a half ago. It really has improved, and a big part of that improvement is the physicians and clinicians at La Paz Hospital. And I can't wait till it gets into a hospital in the NHS or hospitals here in the US, because we'll start to see that. But what makes that work is that skepticism. I do think we have to engage with hospitals or with clinicians in hospital settings, providers in general, and find out what that skepticism is about, because there are many different reasons for it. Mm-hmm. I think one is some people think these tools aren't validated, and that's true. They're not properly validated yet. We really need to go through real rigorous IOB processes and scientific processes that are well established, and these tools need to be held to that higher standard in order to do this. So that's the first thing. But there are other things about AI that are disturbing, and I've just come back from HIMSS last week, and one of the talks that I went to that was most interesting was the bias and the ethical aspects of AI. It can be it can be misused very easily. And I'm sure that could be another skepticism. So, what is the bias that you're bringing into this? If you're only training a model on rare diseases and somebody puts in a normal genome, what's the tool going to do? Is it going to spit out a rare disease? So those are the kinds of things that we really have to start thinking about. A third area that we hear a lot about, and that could be an objection by somebody, is that this is data in the cloud. And is it secure? Is it private? And then my favorite hospital that really focuses on patient experience would say this if we took it to them. That's Cleveland Clinic. And they would turn around and say, the most important thing, as I ended my talk with, is not the technology, it's the empathy that goes into it. So how do you build empathy into this kind of technology as well? There are lots of ideas, but I think my view would be we need to talk to those.
Welcome the skepticism.
Welcome it, but in an open discussion, not a biased way.
Let me throw something on top of that, and I think you make an important point. For common diseases, you can do these at a few centers because they have a lot of patients. For the rare disease world, this kind of, I hate to say it, but almost this eating our vegetables process where we have to accumulate vast experience with these conditions, which makes machine learning and AI, I think, possible. We have to do it at multiple centers. The patients have to be involved. You really need a global effort because you've got backgrounds that will affect how these diseases present, whether it's in sub-Saharan Africa or it's in northern Canada. Those are going to have differences there, and we've got to pull that data together. As we do that, diagnostics get better, but we've still got, I think, a huge process in front of us that we need to do to really make those things hum. And I got to admit, I'm incredibly encouraged by how fast it's moving.
But I will say, though, and I think you raised a hugely important point, and that is not just the skepticism, but what do we do in terms of the patients and the public, quite frankly, right? Because at the end of the day, as you were saying, it's going to be the support. And then part of the question is, how do patients retain ownership of some of that? How do, so that's at the individual level, right? So I'm given my information, I'm putting it in, what do I get back? How do I make sure that I continue to control how much it's used, where it's used, how else it's going to be used? And even as you say, it could be tremendous learning in an AI perspective, but how do I make sure it's not going to be used in ways that I, can no longer control? And I think we're getting some of those. I think the other thing that we talk about, though, is making sure that we continue to engage, and that's why I've been so thrilled with this whole commission, is how do we build in patients and patient representatives right up front so that we can continue to talk about the issues like what are the ethics of it? What are the concerns that families are going to have in terms of, having this as part of, the information set that's out there? We all talk about big data, and I think for individuals, this kind of, in some respects, it's exciting, but it's a really scary thought. And especially as we see some of the kinds of concerns, even under the best conditions. So I'm really excited by, I think, where we're seeing this going. But I think it is our obligation to make sure we never lose sight, that we need to make sure that we're continuously going back to saying, how do we make sure that this is going to work? And I was very much impressed in being part of an IRDIC, International Research Consortium on Rare Diseases project on a model consent form. And that, to me, is something we could think about. How do we actually have these kinds of global consents? So it's not only, but it's also education to the researchers, education to the clinicians, and also a safeguard to the patients, right, in terms of here's what the ethics are, here's what's being explained, here's what's being used universally. So I think all that technology is exciting, but as you say, let's not forget that at the end of the day, patients and parents need to feel really a part of it and feel really that they're being respected all the way through and continue to own it.
And how do we make sure that that's globally applicable and bring services to people and patients and families in areas where there aren't geneticists?
Exactly. Good. Because in most cases there aren't, right? And I think that third thing, how do we improve the genetic counseling? So, I mean, I've had many people come back to me and say, and what do you do if you don't have a genetic counselor? Like, what do I do there? But are there ways that we could do it more remotely? Are there ways that we can, kind of tie into, as you say, sites and centers where there are? What's the obligation in terms of training up? The more we do this, the more we're going to have to train up the counselors, et cetera, to actually be available. So that becomes a human obligation, I think, if we're going to do this from a technology point of view.
I just thought of one more skepticism that I'm hearing. Some doctors, particularly specialists, think that these tools are going to replace them. And I actually ended up talking to a group of radiologists about 6 months ago, and the biggest concern in that audience when we spoke about AI and imaging and how AI was starting to be used on was they felt that their jobs would be taken away from them. And so, I think there's that piece that has to be dealt with as well.
I would, as a clinical geneticist of 30-plus years, I have no worries about that. There are more blue whales per people on this planet than there are clinical geneticists. The ratio is about the same, which we won't go there. But I think, to me, these will always be assistance tools. These are things that still have to be integrated with the patient, with the family. You still need someone who can interface, help get that information the family's bringing into a form where you can analyze it, because there's still some gaps there on how you put things in. If I use the word seizure, how many different seizure definitions are up there? How are you going to classify which one you put in? So, we have to do a better job on standardizing. I also still think, and this kind of comes back to some of the earlier discussions, having the patients drive the process moves the process faster. One of the things I've always found, medical centers and institutions tend to be fairly conservative. They tend to be more worried about what's the risk of us doing this. And then I'll have a family's like, I need an answer. And we'll push a little bit harder and faster. Now, they still need to be informed. They still need to know what the risks are. But I will find actually they'll drive the process faster.
So I've got one more question, and love for each of you to answer it. I think we've got 5 more minutes before we'll go into Q&A here. And it's, we all believe we've come up with some great ideas over the course of the last year coming together, but we have to implement them, right? What are the barriers that you think that we need to kind of get through, the skepticism, right, that's out there, that we need to get through in order to implement many of these and have, kids actually getting diagnoses much faster?
You want to start?
I think a lot of it's the interoperability of the system. So, for example, one challenge that I have actually is more in my work with cancer patients, but also with rare diseases, is that people have imaging, so x-rays, and they have them on different systems in different hospitals. And if I want to look at them, I have to get somebody to physically send it to me, either electronically or in post. So we're working on an electronic solution where everybody will be able to automatically see, without pushing or pulling, but see the imaging in different hospitals. I think those sorts of solutions speed things up and are real enablers in trying to improve diagnostic processes.
I would say clustering the information around the patient, not around the medical center where it was generated. And that speaks to interoperability. It speaks to, there's really not much incentive. We have our electronic medical records feel like the fruits of 1960s technology currently. There are some really bright spots there, but the systems are really not built more around patient diagnosis and care. They're built more around the administrative issues that come up around managing a patient, orders and things like that. So one of the departures I think we need to really make these things work is literally interoperable systems where the data follows the patient, not is locked to the medical center.
Wow, 1960s. I think I still had a black and white television. It was one of these little boxes, so I'm imagining what you're talking about here. I would
carry a handful of punch cards around.
Oh, that was my first thesis. I remember that too. The challenge for me, quite frankly, is kind of looking with an RDI hat, is how do we leave nobody behind? I mean, I'm looking at what you're talking about, I'm looking at what you're talking about, I'm looking at what you're talking about, and as we say, that might be great if you're in the environment where that can happen. The challenge is, how do we make sure as we're moving forward that we don't end up with, like the leading edge is going to be way out there, and we'll have all these fancy tools, and we have all these informed patients, but how do we make sure that we're bringing along everybody? And I think it's a huge opportunity to do that, but I think we have to think about that from the very beginning. It's sort of like when we're talking about the universal health coverage, and how do we get, rare diseases into this globally, and it means that as you're developing these systems, and we're encouraging, the WHO to say that for us, as countries, or emerging countries, are developing their healthcare systems, that they also include rare diseases, so we leave no one behind. And for us, that's the same challenge. We're developing these, and these are bright and shiny tools, but how do we make sure that we don't leave everybody else behind? And we don't have as an afterthought, there's many millions out there that we're not really addressing. And that's a big challenge.
Can I add a story on top of that? So we run a genetics clinic in Uganda about every year or every other year. And what we'll typically find is we'll find some teenagers with Down syndrome, one of the oldest diagnoses in the field in genetics, and one that a lot of clinicians can make but still gets missed, who've never been diagnosed. And chromosome analysis, which has been around for 40 years plus, that's the monthly clinic budget. You know what we did find, though? Everybody's got a smartphone. We can find a phone anywhere we go, and what we started doing was, we take pictures, and we get those digitally analyzed. And so I think one of the ways we reach into areas, we're not going to ever be able to train enough geneticists to meet all of these needs, and it's a model that we probably need to evolve. But we can use these expanders to get to the other one else. So even though we may be out here doing these things, I think we can build tools that are applicable in these situations.
That's right. That's wonderful.
Clifford, do you want to wrap up the discussion here?
I agree with you, and particularly accessibility. And there are just going to be so many areas of the world. I grew up and studied medicine in South Africa, and I can think about a child that I used to go and see, and this whole journey through rare disease has made me think about this child with Sturt-Weber syndrome. But, you know, so I do think what you say is really important. The only thing I would add to that is all of that should happen, and we need it to be private and secure, because people won't accept it if it's not, and it'll be abused if it is.
Yeah.
All right, so we're going to take some questions from the audience. So we have a few folks with microphones walking around. Please wait until you've got a microphone so that folks watching online or in Brussels can hear as well. Yeah, go ahead.
My name is KP Singh. I come from Hong Kong Alliance for Rare Diseases. I'm also the council member of RDI. Thank you so much for the panel discussion, which is quite enlightening. My question is, I always see that many breakthroughs are coming from the science and technology, but I'm always query whether our clinical practice, our clinical protocols, and the healthcare system, and even the curriculum in medical schools can catch up with these breakthroughs to make it happen to the patients. What I mean is that always the breakthroughs may be rare practice in the medical field, but I want to have your answer how we can translate this rare practice into common practice in the diagnostic for rare disease children. Thank you.
That's a great question.
I'll take a swing at it since I run a clinical practice in a teaching medical school. The answer is that there's always a lag period. As the new developments roll out, getting them actually into the field, sometimes it wasn't invented here, so we're a little slower to adopt. Sometimes it's people don't talk to each other. I like to use the example of cystic fibrosis. This CF used to be a lethal disorder for teenagers. I've watched a lot of patients in my career not survive that disease. And one of the things that the patient organization actually forced upon the medical community was sharing of treatment protocols, sharing of outcomes, and then actually going to the centers and saying, are you doing the same thing as the other centers are doing with this? And now, actually, the life expectancy in CF really increases almost a year every year because we don't have a back end on that yet. And so part of it is partnerships with the patient community. I can talk to another group of physicians till I'm blue in the face. They may or may not listen to me. When our patients are there with us, when they're advocating too, it's very hard to ignore. So the medical system itself is conservative. New things are often adapted slowly because sometimes there's worries they may be the wrong new things. But with our patients, I think we can accelerate that process.
Your question reminded me of another skepticism we should add when we talk about skepticism.
That is your job today.
Yeah, the process, hospitals are not good at changing processes. You said they're conservative, they resist change, and that's could be another concern. You can see that almost any form of this AI that we're talking about is going to bring about some process change. The example I showed here, where a single-threaded approach today leads to a very different multi-threaded approach in the future. That we have to build into the healthcare system at the moment, and we have to have everyone from the patients to the providers starting to think about how you do real process improvement. And it's not just Lean and Six Sigma, because that's manufacturing, and that's fine. The concepts are fine. But there's something fundamental about a patient and what change means when you think of the journey that a patient goes through. And we need to do more of that. I'm glad to see there is thinking happening in countries around the world. I know some is happening in England. I've seen some in Sweden, New Zealand. I think people are beginning to think about process change in hospitals.
I think it's exactly as you said, though, because, the fundamental systems, right, have to change. But you mentioned the Cleveland Clinic, which is also one of my favorite hospitals, having, grown up in Ohio as well. But you know how they made the biggest fundamental change? It goes back to your role empathy, right? I remember the story the VP told. She got, there was a feedback from one of the patients who basically said her husband had this cardiac condition, You guys are rated at the top of the world in terms of technology. We're not coming there because you're rated number 10 in terms of empathy. We'd rather be at a hospital that had lower technology. And Cleveland Clinic basically said, oh my gosh, this is not acceptable. And they turned around entirely, introducing all kinds of system changes, but most importantly, how do we educate our clinicians to actually be much more patient-centered? So I think absolutely that is the case. But it goes back, as you say, to that personal factor as well. But it's what you said as well. It's that patient being able to kind of have a portal for input that actually, in this case, reaches the very highest level where that system actually can be, that change can actually be driven.
I think we could answer this question. We could spend an hour. It was a great question. Are there others out there?
Oh, yeah.
Yeah. Oh, wow.
Oh, right.
Hi, hello, good morning. I'm Carlos Esteves. I am a father for 2 kids that maybe is a clear example that no diagnosis for 12 years, and is an ultra-rare disease, seizures, and complement. I have 2 questions. The first one is, taking into account the Durkheim words, what's happening with development countries? That is interesting, it's fascinating what happened with the machine learnings, and I have a very good approach what's happening with the kids. But what is the next step in order to get to implement the tools? Now, for example, in my country, maybe the karyotype is available, but not the genome sequencing. What happened in this time that the physician have the potential diagnosis, but not have the tools in order to get the final diagnosis? And the second question is, Health 29 is live now. We can enter and also choose and get some information in order to ensure the correct answer for the patients. Thank you.
So I'll answer the second one first. It's not live and available yet. It's still being tested, so it's a work in progress. There will be proof of concepts, and I think it needs to be scientifically validated. So we aren't there yet, but the effort of the Global Commission I hope is going to drive more and more of these technologies, including the kinds that Marshall was talking about, facial recognition and others.
And what I would say is we're in countries that are developing where, for instance, getting a whole genome sequence just isn't an option right now because of the cost of that. I think electronically we're going to lead. I think that's where the digital solutions are probably going to get out in front of a lot of what I would say the more classic lab hands-on based types of solutions. So facial recognition, algorithms for diagnosis where symptoms are coming in. Electrons are relatively cheap, comparatively speaking, and software once created can be used on a wider and wider basis. The Microsoft folks are probably cringing as I say that. But it's true. You can actually scale those things up quite rapidly. And I would, well, like I say, what we're seeing in, I do a lot of work in Latin America and South America, and some of the digital tools we're using, we're far out ahead of where we are with things like the laboratory testing, things like that. Those are sort of that. We may eventually just run past them, where we're doing a lot of these things digitally. I hope so, because I think that's the only way we actually scale this up.
I think there are some other questions over here.
What Carlo has already said, that in most countries, in developing countries, you don't have molecular study. Right. So we are leaving people behind.
Yes.
And it's a real issue in many countries of Latin America.
Thank you. Hi, my name is Lucas. Thank you for a great discussion already. My PhD is in rare genetic diseases and specifically tools like H29 and others, other algorithms of that nature. And I would argue that the biggest problem is not actually developing more tools like that, because there's a plethora like that already out there, and quite a lot of them work really well. So for example, tools like this on the 100,000 Genomes project get diagnostic yields of 40% and upwards. I think the biggest challenge is actually distribution of those tools and not the development of the tools. So I'd be really curious to get some thoughts on how do you get tools like this in the hands of clinicians who are currently not aware of the fact that they exist or that rare genetic diseases are even a thing. And the second one is, all of these patient families exist online. So if you can't get the tools in the hands of the clinicians, how do you do distribution to those patient families and make sure that they find the right tools?
So I think some of it comes back to what your colleague mentioned in terms of actually educating doctors, educating from medical schools. So why are rare diseases such a minor part of the curriculum when in fact in terms of numbers of patients as a whole, they're significantly broader in their representation. So I think it's about educating medical students, educating them not only about the conditions, but also about their technology, so that drive to use technology comes upwards as junior doctors come into the hospitals. We have medical officers who are in charge of information, and we often appoint junior doctors to those roles because they know they will grow with the roles and influence upwards as they go through the hospital. So I think that's really important. It doesn't address what's happening in parts of the world where the technologies doesn't exist. I think another part of it is standardization, when we've got such a lot of different applications coming through. How do we improve quality by standardizing and showing that we are really providing a connectivity which will enable everybody to work on the same sort of platforms?
You know, I'm listening to you. One of the things that comes to mind is we cannot make this like eating your vegetables. That's boring. Nobody wants to eat vegetables. Why do clinicians go to certain areas? It's not because that's necessarily where the biggest need is. It's where there's some interest, there's some excitement, right? I think we need to make diagnosing rare diseases really sexy. This is kind of like where the big tools are. This is like where the fun is. This is where things are going to actually happen. We need to sex this all up, right?
So that's a great segue for technology, because where there's been great innovation in tools that are widely used, it's been because people have created data sets that are available, de-identified, if need be, in certain cases, and that they put them out there for young, excited developers all around the world to work on. It doesn't happen in healthcare. I'll give you an example. Last summer I did some work in a class at Harvard where they gave them MBTA data in Boston. And the applications that these children came up with, and I call them children, they were 21 years old, but from around the world, were amazing. I mean, they were giving me my personal analytics on how I was using the MBTA and whether I was using it the best way. And they were calculating closest points to go to. Why don't we do that in healthcare? Why don't we create data sets that are de-identified and let people come up with great ideas? That's where you'll get this real exciting interest in it.
So what I'm going to add on top of what Durhain said, though, is without these data sets, without these data collections, okay, let's put some butter and salt on the vegetables so at least they taste good. But that, you know, these, like you said, the tools exist, but they're only as good as the information they have to work from to develop these algorithms. They can't work in a vacuum. So I think part of the thing we do is with the existing tools, we build these data sets like longitudinal natural history studies, like patient data collections, where those are pooled together. Then those algorithms become that much more powerful.
Yeah.
I'm just going to add one other thing, because when the work that I do at the Mighty is it's all about distribution, right? And I think what we've seen is that healthcare is not by nature very engaging, right? You want to go to a basketball game, you want to go see a concert, you don't want to go to the pharmacist, you don't want to go to your doctor. And so if we can make it more appealing, I don't know that I could go as far as saying it's sexy, but if we could make it more engaging, we think it's through personal stories. That is where people come together. It's relatable, and that's how we're trying to bring and build community together. Is really through that personal side. That's what people can relate to. They're much more likely to find the tool that we showed today if they may read a story and then it's attached right there. Like, oh, now I know what's in front of me. So I think that's a way that. To actually make healthcare or make rare disease sexy it's the personal stories. That is what's bringing folks together.
I just want to add that endorsement, because if you have not seen the Mighty as a website and as a portal, it's amazing. And there's so many communities in there, and every single thing is driven by the stories. So you're going on there and you're learning a whole lot, and it's also great for patients in terms of sharing families, but out of it comes, as you say, some incredible learning. So if anybody has not seen it, it is such an incredible resource. I really salute in terms of what you've done with it. It's incredible.
Do we have one more question, or do we jump to Brussels? All right, so we're going to, I think Tasman Rose, is going to join us from Brussels. She's got been having a conversation there with a number of people, and she's going to join us and give us a little bit of a recap, I think, on what they've been discussing.
Hello, New York. This is Brussels calling. Can you hear us?
Yes.
Yes.
Good. Excellent.
And we can see you,
I'm
too.
not sure if you have any visuals yet.
Yep.
Can you see us?
Yes.
Yes.
Good. Okay. As you say, we've had a really lively conversation. A small group of patients, policymakers, clinicians, and researchers have been talking about where we go from here. And there was a real sense of excitement in the room that we are at a critical time. The momentum is finally moving forward. So we talked about how the elements of the Global Commission build on and strengthen the work that has been done at European level for 20 years on rare diseases, and the complexity of getting interoperability of data, medical health records and others, to flow within one national country where healthcare can be fragmented and then across borders. So this is an ongoing challenge, and we heard about different ways that the EU is trying to facilitate that process. But the message came through very clearly about the need to collaborate from primary healthcare, from the GP, the family doctor, right the way through to the specialist, and giving patients more power and more access and more hope throughout it all. We had some talk about data protection and ethics, and one of the questions that we actually wanted to put forward to you was to find out a little bit more about the H29 activity, because that sits in Europe, and of course we have the GDPR, which is the legislation that covers data protection, and there's been some concern that this limits the ability of use of data for further research. So we would like to hear how patient involvement and patient consent has been used in this pilot project to see what lessons can be drawn. But generally there is a commitment to the 3 tracks, a sense that it will help get things moving, and the intersection of technology, patients, and clinicians together is on the edge of starting to make a real difference in people's lives. So the message I think we'd like to hear from is this pilot project that looks very interesting in Spain. How have you dealt with the issue of consent of data?
Jump to Spain to get the answer. I think Julian is listening in, but you can. No, I'm kidding. No, I would have to ask Julian and the team what they're doing. But I believe Julian is listening in on the call today because it's being live broadcast everywhere. So. I'm sorry, I can't. It's an important question. At a general level, we could talk about GDPR and what we think about doing, but I think you're asking specifically what kind of consent has been built into this tool. I think you're raising a great point, and I think we'd encourage Julian and the Microsoft team in Europe to work with you on this as well, and with us.
We'll make sure we put the 2 of you together after this call, and I'm sure he can answer the question.
Isn't Elena there? Is Elena there?
I am. Yes, she's right up there. They don't even know she's there.
So she can work with Julian. She's Microsoft's healthcare representative.
Yes, absolutely. I mean, I would say that the first thing is to be said is definitely, that solution. And actually, Julian pointed it out. We received a lot of support from John Frank's team on making sure that it was up to standard in the implementation time of GDPR. But what you're asking is a couple of levels deeper, is specifically what type of consent, and that's what we need to check with the team specifically. Okay. It's a very, very good question because it allows also how far we go on data collaboratives, data donation, data sharing to take this one forward, much farther. Yeah.
I think here in Brussels we really recognize the potential contribution this could make to families to be able to get a faster diagnosis, and for a clinician, whether a family doctor or a specialist, to have access to the wealth of knowledge that AI and big data sets could give them. So I think the key message was, how do we make this happen? How do we remove any barriers along the way, whether it's public attitudes or legislation, to make it happen?
Let me throw something in. I noticed Pam Gavin's out in the office, out in the audience from NORD. She actually runs the registry program there, and it's one of the commissioners. This is the same problem we have with natural history studies in the U.S. If you base them at the academic institution, that typically means you have to reinvent the wheel as you go to each different academic institution, which in rare disease generates huge barriers because each one will want to put their own little spin on how the ethics are done there, and some of those are appropriate, and some of them that, in the U.S., Harvard doesn't trust Yale, and vice versa. What we have found, though, is when the patient organization is the driver of the ethical consent, and it still has to be done properly, it still has to be done, in the right format, that actually simplifies things because going through the patient organization, then the patients can consent back through their organization, and it's non-institution based. And that sounds like kind of a technical issue, but it actually suddenly frees you up to do a much wider collection where the patients are well informed but are also driving their own consenting.
Yes. Well, thank you guys very much for being a part of this, and I'm sure we'll learn more about all the discussion that you folks had there. And please, a round of applause for our panelists today. Okay, get up. So I want to throw it to Jan, who's going to give you the closing remarks of what we've done, really as a commission, and he can take it from here.
Thank you very much. So my pleasure to try to conclude this lively panel and discussion. So the colleagues in Brussels say technology, patients, clinicians, and I think we heard a lot that the drive comes from these three element, the drive of the technology, but also the drive of the patients, and that a lot of the changes that were mentioned is by having the patient driving the consenting, as Marsha was just saying, but also having the ownership of their data and taking responsibilities in accessing some of the care. So to express fully the potential of these technologies, we cannot separate from the policy environment. And we've worked in the Commission so that we look together at technology and policy change at the different level in order to have a full potential, a real impact to actually improve the time and the quality of diagnosis. I will go quickly through some of the policy recommendations that you have in the report. And first, we suggest that these policy recommendations be integrated, implemented through some of the policy work, which is now developing at the global level, progressively early steps, but at the United Nations and the World Health Organization. But even more so, where today there is strategies and policies in place, US, obviously, Canada coming to it, Europe all over, as it was mentioned, and as they are working in the member states and at the European level at new steps. But I would mention also the Asia-Pacific Economic Cooperation, the APEC, which is starting to work as a task force already on blood products, but is developing on rare diseases. And that's huge. That's huge. That 40% of the population, 60% of GDP. The benefit that we see for this recommendation is to improve efficiency, so encourage the use of disruptive technologies. It was mentioned several times, blockchain. Blockchain is interesting. Maybe blockchain can be the passport for patients to have real ownership and control of their data and an history of the use of it, with all the questions of consent in the middle. Also the genetic sequencing, and maybe we need to see if the whole genome sequencing is the next frontier to go frontline or not. There is debate about it, but maybe it might be a first intention test in a certain situation. And also the advanced data sharing on diagnostic. And that has to go hand in hand, as I mentioned initially, and as it was mentioned during the panel, with innovation in the healthcare system.
it's not just to plug this new technology and new approaches in the healthcare system as it is. It will help. Already we can progress, but we need to transform some of the healthcare system. And a key question in the middle is the cost. We believe in the Commission that these new technologies and advances can help reduce the cost. Now we need to make the proof of concept of that a little bit more to be fully convincing. But that's at least that's what we believe, and we also need to work from what we believe, not only from the facts. And the third benefit that we see is that these technologies are empowering the patients, not only the patient advocates and the groups, the collective, but the individual in their journey through the healthcare system and with their diseases. And I would insist on one element is a journey over time also. So from one hospital to another, but also over life, from transition between children and adults, or when you're moving from one region to another, or from one country to another, or at different steps in your life. Well, recommendations are focusing in 4 key areas. The centers of excellence. And you heard it from the panel and from Marshall, for instance, that the national healthcare system needs to develop these centers of expertise, but also we heard from our colleagues in Brussels the link between the primary care and the centers of expertise. And that's essential. So we need to raise awareness of the primary care providers, and we need to have a link, the referral to the centers of expertise. Second element is the data sharing, the level of global benefit of the cloud, potentially, data storage, although there is the debate on the legal and regulatory aspect here, not to mention the Data Act and the discussion. So that raises immediately some concern. But every proposals and pilots that are in the Global Commission are respecting the European regulation on data protection. That is a commitment that is made into it. And the data sharing is also about the interoperability that was mentioned on several occasions. And that, so the policy, the health policy in our different countries or at the international level should encourage the data sharing across borders to increase the likelihood of match also of the most rare diseases internationally. Few examples of this recommendation include the government support to national umbrella organization of patients or international platforms, but also platform of dialogue between patients and all stakeholders in this area of rare diseases. The pilot presented by Clifford, when they will be mature and upgraded, can really be transformative, because we don't need to wait for the healthcare infrastructure to develop all over the world. We can already take action. And we see this tool not only to be used by clinicians, but as it was mentioned, also used by the patients and the families themselves. Not to have a diagnosed, but to know where to go much faster. So we can be on this front line, exactly like today we're booking our plane when we used to go to an agency before. Here we would be already doing the triage ourselves of our issues to speed up, because we are concerned, we want to go fast, right? Standardization of diagnostic and referral protocols is another recommendation for primary care and centers of expertise, but that goes with the infrastructure for the development of the sequencing. And the primary care technical training to incentivize the adoption of these technologies. And that's part of the adaptation of the healthcare system. We need the people to be trained in hospital, but also outside the healthcare providers to accept these innovations. Now, to conclude on this, I would encourage everyone to disseminate the reports and the recommendations. Try to take action from it. As it was said by one of the participants, not only to develop the tools, but to distribute the tools. Thank you for saying that. That's really, I think, a key element in what we're doing. And I'd like to mention also, to make comment, that this Global Commission is the first time for UORDIS as a patient organization that we've been working with private actors for a scientific committee. Until now, it has always been embedded into the European Commission, the European Medicine Agency, or the United Nations. So it was a first, it was a risk, and we have no regret. This premiere for us is a success. We're happy with the outcome. We committed to disseminate and to encourage our members to disseminate the outcome. But also, I would make the link with the Sustainable Development Goals of the United Nations, the Agenda 2030, where the 17th and last Sustainable Development Goals is about partnership and public-private partnership. And here we can set this Global Commission as a good practice, as an example of where to go, and try to promote it along this line. And this first report is presented back-to-back to an event taking place tomorrow at the United Nations as a policy event, in fact, of Rare Disease Day. And many of you in this room will participate tomorrow. And the objective of this event is to reaffirm that rare diseases are part of the United Nations Agenda 2030, of the Sustainable Development Goals, with the theme of leaving no one behind. If we are serious about leaving no one behind at the United Nations and the member states, then rare disease comes in. And that's where we're going. That's where we're progressing. And tomorrow also we want to promote universal health coverage for rare diseases, to have rare disease into the political declaration coming up in September. And what we will call for tomorrow, with the support of 15 member states in the room and agencies of the United Nations, is to call for a United Nations resolution to address the challenges of people with rare diseases. The Global Commission is part of that effort, of the global efforts, and there is not only this one. There is the IRDIC, the International Consortium on Rare Diseases. There is different organizations which are stepping up to take global action and bringing together the actors in technologies, in health and in digital, but also in other areas, physics, nanotechnologies, imaging. I mean, there is more than this area, right? And also bringing together the innovation again in the healthcare system. We need to promote this innovation. And rare diseases, being at the margin of the system, can be transforming and becoming mainstream, because a lot of what we do and what we're doing in this Global Commission can apply much broadly beyond rare diseases. We are at the margin of society and science, but we're creating the mainstream solutions of tomorrow. That's at least what I would believe. And with that, I would like to thank all participants in Brussels for being with us, and the colleagues from the European Commission, particularly Stefan Schreck, also being with us. And I'd like to thank my two co-chairs and all participants in the panel today. You've been fantastic. And to all of you for attending today. Lunch is just outside for the one in New York, for the one in Brussels. We leave it to you to decide where you have dinner. Thank you.
So if we can get started, I think we have a lot of people that are still drifting in. But out of respect to those of you who have actually shown up close to on time, I think we want to get started. No, we actually have a wonderful program for the afternoon. And hopefully, those of you who are here this morning, and we had an opportunity at the RDI annual meeting, you got a taste of some of the sessions that we're going to be talking about today, but this really is the opportunity also for people to actively participate. So my name is Durham Wong-Rieger, and I am really pleased to be here as chair of the Council for Rare Disease International. I also serve as president and CEO of the Canadian Organization for Rare Disorders and have been involved with RDI since its inception. So we're really, really excited to be here at this time with, I think, the opportunity to really share with you many of the activities that we have been able to accomplish over the last year, but as importantly, and probably a lot more importantly, many of the things that we're embarking on for the next year, and are certainly in terms of our vision down the road. So this is a great opportunity. How many of you are actually just at the Global Commission just now? So some of you had an opportunity. We'll come back to a little bit of that as well. I just wanted to take the opportunity to start to talk to you about just the origins of Rare Disease International, but not necessarily in terms of its deep history, but to really talk to you about where the vision is and where it is that we're hoping to go. So many of you have been involved for a number of years, have been part of our journey going forward, and right now, I think we're at a very exciting time. Those of you with us this morning will have heard that as of the beginning of this year, Rare Disease International is in fact its own incorporated entity. So we now exist as a standalone entity. Many of you will know is that Rare Disease International started as a project of the European Organization for Rare Disorders, as EURORDIS. Many of you, as I look around this room, will be part of EURORDIS as a part of the European Union, but many more of you will be like us, in Canada, who are not part of the EU, but actually saw EURORDIS as being that opportunity of belonging to a much broader rare disease initiative. And I always say over and over again, if there had not been a EURORDIS, there would not have been a CORD. We would not really have existed as a Canadian Organization for Rare Disorders without all the work that EURORDIS has done, and also all the generosity that EURORDIS showed in terms of bringing in patient organizations from outside of the EU to be part of their development, and the sharing of everything from the leadership, the expertise, the tools, the support network that was part of it. I think as many of you will have recognized over the years, EURORDIS was probably a bit more overwhelmed by its non-EU members than by its EU members, and that's not to say that was a bad thing. I think what became even clearer over a number of things, right, is that there was still a necessity for EURORDIS to continue to champion the advancement of rare diseases within Europe, and certainly with the EU, and as a partner with the EU, which is, of course, a major platform in terms of everything from the sponsorship in terms of rare disease drug development, orphan drugs, the working with the European Medicines Agency, and certainly the advancement in terms of the orphan medicinal products relationship. So there are certain things that within the EU continue to be important, especially as some of the initial program packages have begun to roll up, and there was a necessity to continue to move forward. I mean, as you all know, EURORDIS, under the leadership with EURORDIS, but also in partnership, obviously, with the EU, were many important initiatives, including the call for national plans for rare diseases across the EU. There was certainly the vision for, and actually then the implementation of European reference networks. So multi-country, multidisciplinary centers of excellence that actually became into existence, I think, 26 or so of these. So, I mean, amazing initiatives that, again, from an EU perspective and from a EURORDIS perspective, became still an important initiative, not just for the EU, but for the benefit of models and participation of others. But at the same time, I think we also had a growing awareness of the need to serve members outside of the EU and to be able to collect in people into an environment that was actually going to, in some respects, specifically address the needs of member organizations, patient alliances, but also nations that were just beginning to develop rare disease plans and strategies, that were also in the early stages of even developing health systems. How do we actually embrace those? Latin America is a huge example. Asia Pacific areas are a huge example. And certainly for us in Canada, I always feel like we're kind of the orphan of the orphans. You know, there we are sitting next door to the biggest country with regard to their national organization of rare disease and their plans. And then we've got, you know, Europe with everything that was going on. And of course for us in the health system, much more aligned with Europe than we were with Canada. It became hugely important, but also as we looked increasingly in terms of what was happening in Asia Pacific. So the vision of having a rare disease international alliance actually became even more important. Certainly to address countries outside the EU, but also to address issues of newly developed emerging healthcare systems, low and middle income countries that were also coming into it. And I think brilliantly, the notion that we needed to engage global actors. That Eurorders, as valuable as it was in terms of addressing the issues around the EU, was not going to be able to, on its own, actually be able to command the participation, collaboration of the major global entities like the United Nations, like the many organizations within the United Nations, including the WHO, including UNICEF, including the ECOSOC, the Economic and Social Organization. So can we then have a global patient alliance that would actually be able to work then at that same stage? And as we know in the rare disease environment, right, it's always been patients, and it's always been patient-driven. I mean, it happens in all the diseases to many respects, and we have great examples from HIV, from cancer, from certainly some of the blood disorders, etc. But I think in the rare disease, it's been especially the case. So out of it has become the move towards a rare disease international. I think for many of us coming into RDI and being part of RDI was a little bit of a leap of faith. I think nobody really was sure that it was actually going to take hold in the way that it did, or take hold in the time that it was going to. I think Jan was the only person that really believed in it the whole time. And we all sort of, you know, got caught up in his orb to basically say, okay, I guess if Jan is going to be doing this, and you know, and Jan, you know, not to put too fine a note on it, you know, has brilliantly taken a lot of the development that took place in terms of Eurorders and the EU to say, okay, we can now address this on a much more global stage. And I don't know how Jan continues to actually serve both the European community and the rare disease international community, but we're really grateful that he's been able to figure out a way of cleaving himself in terms of being able to do this. I mean, and actually, you know, what also happened, I think, brilliantly, is putting together that first Rare Disease International Council, where, again, we were able to pull upon different member organizations from right around the globe from its very beginning. So, you know, we've come to this point now where we actually, as we said at the beginning of this year, now have our own actual entity, probably years ahead of what we thought it was going to be. I think the vision was that it was going to be much slower than the pace that we went, and not because nobody wanted it to be, but because there were certain practicalities that were going to be involved, not the least of which was funding. But I think we've managed to work that through because the recognition was very clear that unless RDI, the Rare Disease International, was going to be able to be an entity that had its own integrity, that was able to approach the major global organizations as a true international movement, that we were not going to be able to have that same kind of support and engagement. So we're at a wonderful point. This afternoon, you're going to hear about some of the activities that we've done, and you're going to hear a lot about the activities that we have done that are leading up to this kind of global participation. As we said in the AGM this morning, you might feel, for some of you who are here as patient organizations that have really looked at a global entity to say, what can you do to help me in my own country? You may not necessarily understand as intuitively that all of this really is for all of us. But on the other hand, and I think hopefully we all recognize that only by moving forward at this global level that we're going to have the opportunities to advance in many of the ways to, not though to negate the fact that we also need to do a great deal and a great deal more in terms of working with the member organizations. RDI is a membership organization. There's no doubt about that. So this morning we had a vote in terms of the activities and the budget, etc. But it really is not just a membership organization in principle. It's not just a membership organization in terms of its governance. It's genuinely a membership organization in terms of its execution. So you're all here, and you all recognize it, that you're not here to be just listening to what it is that we're going to be presenting to you from what the council has been doing or from what the staff has been doing, but you're really here, and I know for many of you, you've been part and parcel of lots of the activities that we're doing. You've been very much, as we say, boots on the ground helping us in terms of many of the work that's being carried out, and not just the member organizations, but many others as well in terms of volunteers, in terms of partners, etc. So I just wanted to give you a quick high-level overview of where we are, because you'll hear a great deal more specifically as we're going into it, but also just to welcome all of you. This is exciting. This is the first time we've had an RDI in North America in this respect. It is the first time that we've been able to put it into some major events that are taking place. Those of you who said we just came out of the Global Commission to end the Diagnostic Odyssey for Children with Rare Diseases, which has been a major program that has been brought together by Reuters, by Microsoft, and by Shari Takeda, a very unique kind of a joint initiative, which hopefully we'll be able to move forward, and hopefully will not be the last kind of project that we'll do of that nature. So I think these are interesting opportunities for us. We'll also hear a whole lot about what we're planning to do, though. As I said, tomorrow, with the non-governmental organization for rare diseases, which was launched back in 2015, 16. Time kind of moves on. Yeah. But no, seriously, and it's amazing that we're going to be able to talk about what is taking place tomorrow. We want to give you a little preview of what will be taking place, because not everybody can actually come to the NGO meeting that will be taking place. We really apologize for those of you, and we know that many of you wanted to be there. We're just limited by the size of the room and the space that is there. So we're really, truly sorry that we can't get everybody in it, but we'll give you a little bit of preview, and hopefully, it will be webcast so that others can take part. So with that, as a very quick overview in terms of where we're heading, you can see on the agenda, after I get done talking, we're going to really talk about two important things. One is, is that my worker here? We're going to hear about two things. We're going to hear about why and how to advocate with the UN, the overview of the high-level event that's coming up on the NGO Committee for Rare Diseases at the United Nations, and we're going to talk about the United Nations Resolution on Rare Diseases, the objectives, and the progress. We're actually going to flip that order. We're really sorry that Anders Olesen, who's been one of the leaders and certainly the initiator of our establishing a non-governmental organization on rare diseases, a committee for rare diseases, is not going to be able to join us. Some of you will know that he is, in fact, the lead at Agrenska, which is in Sweden, one of our leading institutions there for support of rare disease. Unfortunately, he's come down with some kind of a viral infection, and he's not able to attend. So what we're going to do instead is that we're going to ask Jan to present both presentations. And Jan's going to start off with the second presentation towards the United Nations Resolution on Rare Diseases, objectives, progress, and coordination of our actions. And then I think you'll move directly into the presentation that Anders was going to give in terms of the overview of the high-level event that's taking place tomorrow with the NGO committee. And then we'll open it up for Q&A. Okay, so... Is that right?
Thank you, Duran.
Okay.
Yeah, it's exactly that.
Okay.
So, sorry, because then you're going to have speeches, right? It's Duran, then it's me, and then it's me replacing Anders. So it's going to be, apologies for that. It's not very entertaining. So first I start with, yeah, exactly. Okay. So first I start with a reminder of our overall strategy. For some of you, it's going to be repetitive because we discussed it already last year in Vienna. And also we had webinars about it, but it's to make sure that everybody's on the same page. But I will not spend too much time on that part. So everything starts with the new agenda of the United Nations. After the millenniums, which was the agenda before, now we have the Sustainable Development Goals. And that has started 2015 until 2030. And we prepared for that since 2012, 2013. in these 17 Sustainable Development Goals, which each of them are being detailed with more specific goals. You can find all that on the website of the United Nations. The ones that are more specific to rare diseases are obviously the good health and well-being, but it's not only that. It's also the reduction of inequalities. It's also the no poverty, because we know the impact, obviously, on the financial resources of the family, because you're out of job or one of the parents is out of job, but also all the co-payment that you have to do of your health care. The quality of education makes a major difference in terms of access to care and access to global care, even social and health care. The gender equality, because we know that women and girls have more difficult of access to diagnostic and to care, and the mothers are more affected than the father in terms of impact of the diseases. The decent work and economic growth for everyone, industry, innovation, and infrastructure. We discussed that this morning, so I don't need to repeat that part. And the partnership for the goals. That's what I was mentioning this morning also on initiatives like the Global Commission, which can be part of that partnership. The United Nations are the right place. Why? So some of you may wonder, still now and still after the explanation of the previous years, why we're not at WHO? Why don't we start with WHO and that's it? No, because if we do that, we only reduce to the issue of health, when all issues are much more than that. And also, by going by the route of WHO, we may have some positive, and I will come back to that, but there is also the immediate negative on bumping into the bubble debates about intellectual property, about price of medicines, and etc. So we will be polarizing immediately our approach. So that's why we want to go from the United Nations route. United Nations route has the credibility of the strong public health agenda here in New York, but also the social development and inclusion, which is what we're going to play, and the science, technology, innovation, and the human rights. So I think I have it on the next slide. No, I don't. I have deleted this one. So the New York United Nations is about peace and security. It's about development, and it's about human rights. And development was really high on the agenda in the 60s, 70s, and then lost a bit track. And now it's back. With the Sustainable Development Goals, it's all about development. And positioning ourselves in development means looking for full integration of people with rare disease and their families into society, really a holistic dimension. And it's also using that dynamic of Sustainable Development Goals, which has the motto of leaving no one behind. So United Nations system, so the full system of the UN, has two bubbles. The bubble of Geneva, which is WHO, but also where the Convention on Human Rights is located, and the bubble of New York. New York is where the Secretariat General of the United Nations is, and there is one department which is important and relevant for us, is Department of Economic and Social Affairs, which is participating to the event tomorrow again. And they are important when developing a resolution, but also to report on progress. General Assembly of Members is sitting in New York, as you know, so the permanent missions here of the countries have a role which is large at the General Assembly. It's not only health, like in Geneva, for instance. And there is the Economic and Social Council, so the ECOSOC, and the NGOs are part of ECOSOC. And the NGOs in official relationship with the UN are forming the Congo, the Committee of NGO, and this is where we have located the NGO committee. So that's the system. This is a slide I love because nobody can see it, neither when we do it online or on site here. But have a look at it after that is what I want you to really understand is that when you look here from Economic Social Council, you see where it has an impact. It has a direct impact on the programs of the United Nations like UNICEF or the development program. So what ECOSOC decides has an impact directly. Then after, there is the agencies on which it has an orientation role like WHO or World Bank Group, but it's a different type of impact on the specialized agencies. So, okay, I think I covered that. Just to say that World Health Organization, the recent important work on the WHO has been on communicable diseases, on non-communicable diseases, and we know all the political work, and some of you have participated to the NCD debates, and rare diseases were absolutely not on the agenda. 3 years ago, we couldn't even have a meeting there because nobody wanted to have us in their remit. They don't know which box to tick. So I think I've covered that of New York except for the health agenda. So what's the health agenda of New York here if WHO is in Geneva? What is here is the Sustainable Development Goals number 3 as part of the SDGs. That's political agenda here in New York. Then it's the motto of leaving no one behind in general, not only in health, but also on all the aspects I mentioned before, and the universal health coverage. Universal health coverage is a political agenda of the member states. It's not only a health issue. It's much more political than that. So which progress have we made since 2016? I will go back to that, but the first high-level event, which we put together with the NGO committee in November 2016, that is in our mind. Then there was, and sorry because that was also mentioned by Paloma this morning for the one in the General Assembly, but we had a contribution as RDI and together with the NGO committee at the Conference of States of Parties on the Convention of Rights of Persons with Disabilities. And there was an oral statement made by Clara Hervas, who is now part-time part of the staff of RDI also. And so that was our first contribution, and the contribution made on this occasion on paper and oral was used by the special rapporteur on rights of people with disabilities, Catalina de Vandas, and rare disease is mentioned, and her contribution is in the report, and so that's a beginning of something. But what is interesting with that is that that's the first time that UN makes a report on health in disabilities. Until now, it's always a very well-divided word, right? Disability policy, health policy. And we know our problems, particularly with the polyhandicap, so it's important to bring the two together. So that's just the beginning of an effort, but at least it's a first step. Sorry, I went too fast. Can we go back? Thank you. Then we made a contribution to the Office of the High Commissioner of Human Rights. We did a report on health and the Sustainable Development Goals. And we made it in collaboration with some of the members of RDI, like Thalassemia International and Spina Bifida Hydrocephalus International Federation. And Agrenska, so we submitted this statement, which was taken in consideration. And tomorrow, we will have the number 2 person of this Office of Human Rights at the event. So WHO now, having in mind everything I said about the distance to put between what we do in New York and Geneva WHO, still WHO is obviously very important to us. It's the World Health Organization. So what are the progress that we're making? In November 2016, there was the executive director of the WHO office in New York. So WHO has an office here, and they have a staff for all the work with the UN system in New York. And the director, Natamenat Bey, came to that meeting, and it was a real negotiation to have the right sentences being said at this event. And that has been a leverage to that for the next steps. Then we worked on the candidate for the job of Director General of WHO. There were 7 candidates. We targeted the 4 that we thought had more chances. One of them was Tedros, Dr. Tedros, who turned out to be, after that, elected. And when he was a candidate, he started to make a statement of support of rare diseases. So he was committing before being elected. And then after, when he was elected, we contributed to informally first and then officially submitting papers for the WHO world program for the period 2019-2023 to try to push the language of rare disease into it, or to just to raise the flag and say, hey guys, don't forget about us. And these papers have been prepared with the RDI Advocacy Committee, which is a great group. It's working well. And we had also an event, so that was November 2016, and then in February 2017, we did an event in Geneva on health, right to health, patients' rights, access to medicines, with different participants from WHO and other institutions in Geneva. So with time, in November 2017, we had our first important meeting at WHO. First, you need to understand what is an Assistant Director General. WHO is organized like a government. You have the Director General, which is a sort of Prime Minister, if you want, and the President will be the Chairman of the Board. And then you have sort of ministers. They are the Assistant Director General. They are very high-level people, and it's all political nominations. So in that meeting, we met two assistants, the assistants of access to drugs, vaccine and pharmaceuticals, Margiela Simao, who is the extremely credible leader behind access to medicines on HIV at WHO, and Naoko Yamamoto, who is Assistant Director General for Universal Health Coverage and Health System Cluster. So, and she knows about rare disease because she worked on rare disease in Japan when she was at the Ministry of Health. And then there were other colleagues, particularly Rudiger Kresch, which you will see tomorrow, and who is now our lead contact at WHO. He has been appointed as our lead contact, and is in charge of healthcare system and innovation. And Sarah Garner is in charge of innovation and medicines. And it was not a given, that meeting. When we went there with Paloma, we had 10 minutes. 10 minutes at 9 a.m. to save the world. So really, that was not fun. And we enter in the room and we say, okay, we know we have only 10 minutes. So when you leave this room, we just want you to decide whether you ignore 300 million people and your indifference continue to be the violence that we have since decades, or you decide that leaving no one behind may include these 300 million people. They stayed an hour, and that was the beginning of a conversation. I'm not saying that to show off, but it's only to say that it's incredible, but you cannot get these people to pay attention, even when they know about rare disease, because it's not part of their agenda, that's all. So we need to put it on the agenda. That's the full thing. But the outcome of that meeting was that from that moment, they asked us to develop goals that we could have and actions that we could do together. And then there was internal consultation at WHO. 3 months later, at Rare Disease Day last year, the Director General of WHO, Tedros, made a statement, an official statement, which you can find on the website of WHO if you type Rare Disease WHO statement. And he says, we are working for a world where no one is left behind. We are welcoming discussions with the rare disease community on how we can strengthen cooperation to ensure people with rare disease can access the health services they need. He also says that the vision of the Sustainable Development Goals is a world with no one left behind, including people suffering from rare diseases. That's the first time it was said clearly by an official of the UN system in that way. After that, we worked internally in RDI, and particularly with the RDI advocacy group. So you have not received all the members at large this document. I will explain why in a moment. And we've developed a collaborative framework of 25 pages, and we submitted it in November, and it has been welcomed and endorsed, approved. So we're on track to collaborate with WHO. And this document sets 5 ambitious goals: awareness and visibility, universal health coverage and healthcare, diagnosis, medicines and assistive technologies, and the national strategies, which are clearly running across the 4 ambitions. And then it has specific goals for 2030 linked to the SDGs, but also actions that can be taken in the next 5 years. The next phase now is that we have been invited to submit a memorandum of understanding, which we are doing for the moment in a draft form with them. And this will be hopefully finalized in March or April. And from the moment we will have this MOU between WHO and RDI, then there will be an annual work program. So there is what we have developed for the next 5 years, but there will be an annual work program. From that moment, we will share everything with you and discuss. We will have webinars to have your input and check with you, check and balance if you think it's the right direction and which way to go in terms of priorities. The big news, recent news, is that we have an appointment with the Director General and his staff. Initially, it was said to us that this will not happen before later during the year. But we play poker, and we say, okay, it's Rare Disease Day. Do you want to meet on the 28th of Rare Disease Day? What are you doing that day? And they are giving us an hour, and there is the Director General, there is the Chef of Cabinet, there is the Deputy Director General for Programs, and again, the Assistant for Universal Health Coverage and Healthcare System, and Rudiger Kresch. So we see that as a sign that not only they want to, 1 year after the statement, to show attention to rare disease and to communicate about it, but that also it's a way to push our collaboration and our memorandum of understanding. So we see that as a positive sign. We cannot take that as guaranteed. We can tell you only after the meeting, but we're hopeful that this is progressing. So the next dossier is universal health coverage. I take for granted that you're pretty aware in this room about the agenda of universal health coverage. It's a big thing on the agenda of the UN this year. It's a political declaration to be adopted on the 23rd of September in New York at the General Assembly in a high-level meeting. And what we want is to have rare disease mentioned into universal health coverage, right? So that's our goal. And if I had to say that we have one goal this year for RDI, if I may, we can do plenty of other stuff to push, but that's what we want. So I hope we succeed, because that's what we want. And what we have been doing is a lot of background work with the key countries which are leading the work on universal health coverage. The two facilitating countries, which means the lead countries appointed, are Thailand and Hungary. And the drafting countries, the ones that are playing the diplomatic role and writing a lot and negotiating a lot, is Japan, which has a lot of credibility on universal health coverage here in the UN system, and France. And France, because they are also in charge of what is called foreign policy and global health agenda at the General Assembly. And there is some other champion countries which are identified. So we progressively meeting the permanent missions, often in connection with you, not always, but most of the time. And that's what we need to do increasingly, to work together on these meetings. We were invited on the 12th of December to the kickoff meeting of on universal health coverage. That's a meeting put together by the permanent missions of the countries in New York here, supporting this universal health coverage. And we were invited, and we were the only NGO invited. Wow, that was great. And Duran was crazy enough to jump into a plane while she was in South America, and she was there on time, and she made a strong impression. So that was good for all of us. And now we will be invited again, most probably on the 29th of April, by the President of the General Assembly, who is organizing hearings on universal health coverage. So that's one of the next things we're going to work on. So before moving to that, I want to mention that you have in your folders a 2-page document, which is the executive summary of the draft statement on universal health coverage and rare diseases. So look at it. You will receive by email, right after this meeting in New York, the full paper. So there is a full paper of 20 pages on universal health coverage. You're not obliged to read it all if you don't want. You just read the headlines. But please look at it and send us back your comments. You will have something like 10 days or 2 weeks to look at it and send back comments. Then we will consolidate all that. We will also use what will be said tomorrow. And then we will have the final paper by the end of March, which we will submit officially to the permanent missions of the countries which are playing a key role. And then we will send it to all over. And you will have a role also there. But that's so we can have an impact. The next months are going to be important. April, May, June are going to be the moment where things will be written and crystallized. In July, it's done before they go on holiday. And September is only the ceremony, but it's finished. Yep.
I would like to.
Yeah.
Hi.
Yeah.
I would like to ask if it's possible also to send by email the document, the position statement that also the Federation of Rare Diseases have already done, as I think it's going to be a complementary document that could be also be included for this position statement. So I think if I'm asking the permission, there is some copies over there.
Which have been made for you here, so you can pick up copies of the.
They have already the endorsement of 57 different organizations in our region.
Yeah.
So, well, thank you.
Thank you. We're pleased to do that and to send it. Now, there is one positive, one negative for me in your paper. The positive is that it's a contribution that comes from 57 patient groups from different countries. That's strong, powerful. So send it to your permanent missions of these different countries. The negative is that it's a mix of too many things. You've used that basket to put everything into it. And basically that's the same thing that what you ask in non-communicable diseases agenda and all of that. And that's a negative because it gives, for the people who will receive it here, they will say, okay, these guys are just asking for everything in universal health coverage. So you see, it's a pushback. No, I read it. I read it already, so I know what I read. No. Okay, if you say so, fine. But still, when I read it, I can see that there is elements which are creating confusion. So it's all right, but I just want to say that we just have to be careful that there is not two position papers on universal health coverage from RDI. There is only one. If not, we're going to get confused. But that, I suggest that we use it a lot with the countries where patient groups have contributed to push on the agenda. But we can share it with all patient groups, obviously. It was called universal health coverage, so I guess, no, I think I read the right one. Yeah. Okay, but still, I'm not saying it's negative. I'm saying there is two sides to it. So, okay, so the resolution on rare diseases. Here, so it's clear that it's a resolution to the General Assembly here in the UN. It's important that we all keep in mind not to have expectations too high, that it's non-binding to member states, right? What they are voting is only an orientation. It's an aspiration. It's a journey. It's a direction. It's not more than that. It's a course of action. And it's not binding for specialized agencies, what I showed you, WHO, World Bank, but it is binding for some parts of UN, the Development Program, UNICEF, and the Department of Economic Social Affairs, for instance. A resolution looks like the preambulars and the operative paragraphs. The preambulars, that's what we are working on since 2 years. What I showed you before, to send a report and to be into disability or into health and SDGs, these help us here to develop the language, to say we exist already in the system. We have mentioned here and there. And this is what we would ask for. There is resolutions which are only to recognize a day, an awareness day. It's good, but that's not what we want. We want a resolution which is much more which has much more depth. And here are some examples. You already have them on our website. Much more in-depth, like in HIV or in albinism or non-communicable diseases or in sickle cell, where there is really concrete elements, into it of what is being said to the member states and ask from the member states in terms of healthcare or etc. And also to ask for regular reports on the situation in the different member states in terms of implementing this resolution. And the process will be that we will need one lead country and several countries as co-sponsors. And then after, we will have to build a larger momentum. And that's why this morning Paloma mentioned that we will create the Friends of Rare Disease, so to trying to bring the permanent missions in New York and in Geneva who are supporting this agenda. So I conclude with working together. And here I'd like really to say thank you to all who have helped in reaching out to your permanent missions already. And we are clearly understaffed compared to the work we do, so that's why we don't always do it. Sometimes we take a shortcut. Apologies for that. But what we want to do more and more is to do it with you for each of these countries. So we want to coordinate with you so that you reach out to your permanent mission and you reach out to your Ministry of Health and to your Ministry of Foreign Affairs if needed. Because what we want is to have an impact, and when the permanent mission in New York decides, for instance, to co-host a meeting like tomorrow, they are not deciding by themselves. They're always checking with Capital City back at the government level to check, can we support or not? And what we will learn to do here with universal health coverage will be useful for the UN resolution. It's going to be the same process. So we're building also the capacity of us as a network. The UN declaration, we will use the joint declaration that we have already adopted in RDI a few years ago as a basis, so we're not starting from nowhere. And the next step for you as members is to reach out to your Foreign Affairs Ministry. There is always an office in charge of health. Ministry of Health, there is usually someone in charge of international affairs. Always mention that you want to link both to New York and Geneva. And then to reach out directly to the permanent mission in New York and in Geneva. So even if we don't have anything special at the moment, you could just write them and say, I want to introduce my National Alliance. We've done this event in New York on the 21st of February, and we will get back to you. So just that they get to know you. The Friends of Rare Disease, I mentioned already, and yeah, I think I mentioned that. For some countries where there is no national alliances, we will have to work more closely with international federations, which we have not done yet very much. So it's about that. I hope it's clear and understandable. Any question before I move to NGO committee? I know it's a bit killing after lunch to have all these speeches like that with a microphone, and it's already killing for myself. Okay, so I go on. You're still awake? Okay. If I see one sleeping, Okay, so now...
Audience,
okay. So now I'm Anders Solosson, right? I'm Anders Solosson. So poor him is suffering with his bad infection and ribs, muscles, ribs. So the NGO committee was created within this committee of NGOs. What you need to understand to get it right, so that when you speak about it, you're able to say it right, is that the committee of NGOs can establish what is called substantive committees. And Rare Disease is a substantive committee, which brings together NGOs. What a surprise. Which means, in fact, in other words, civil society. So overall strategy is New York, development strategy, sustainable development goals, but developing a power through the civil society to engage the policymakers. That's the strategy. The exact words that you can use is what is here. The NGO Committee for Rare Disease is a substantive committee based in New York of the conference of NGOs having a consultative relationship with United Nations. You need to breath, but that's the exact name, right? So what is this NGO committee? And is it important to make it big and have a lot of money and a lot of staff? No. The NGO committee is just a nutshell on the ocean of the United Nations to influence from inside. The big difference is that either we are outside and we're sending letter and we're asking to be invited, or we are inside on our little boat trying to navigate. That's what we do. So we have our little boat, and that's the vehicle that we're using. The initiative was started thanks to Agrenska Foundation. Really, we're lucky to have this dedicated team. Is Robert in the room? Robert is not in the room. He's escaping? Working outside. How is that possible? So they are not so dedicated, you see. And also with Odyssey, and now as Rare Disease International is shaping and becoming and being a legal entity, then it becomes also Rare Disease International. Mission is to promote rare disease as a global priority in the UN Sustainable Development Agenda. You're not surprised because that's the strategy, so it's aligned, it's normal. And the vision is to be inclusive, multi-stakeholder. Let me insist on multi-stakeholder. We are the only Congo substantive committee saying that we want to be multi-stakeholder. Why? Because everything we do in rare disease is successful only when we are multi-stakeholder. I can see that Anna and everybody is nodding, right? So we wanted that. That was accepted because it had to be accepted by the board of directors of Congo, and so that's what we're doing. We have an inception board until we have sufficient members to have an election. And on this board, I think I have photos here. We have Leven, which is here. You have Alain Vey, right here. We have Kawaldip Shemi from the International Alliance of Patients Organizations. We have Sun Young Yoon from the Alliance of Women. I don't think Sun Yoon is with us. No, she's not today. And so that's the group. So that was the event in November 2016, you remember. So Global Gathering for Rare Diseases was this format. We will be in the same room tomorrow. And this agenda, which was really to put rare disease on the agenda of Sustainable Development Goals. So we had people from the UN system coming and saying that. That was the whole point, to have them saying it. And at the end of the day, we had this act, so-called funding act, on rare disease and the Sustainable Development Goals, which was signed, including by the people from the UN system, just saying very reductive and simplistic ideas, obviously in bullet points, but still it says it, that rare disease is an international public health issue, common challenges across disease, across borders. One country or one continent alone cannot solve all problems, that we need common national policies, international collaboration, that it's patient NGOs and other stakeholders aligned for partnership, and also that we fit into the SDGs. So the policy event of tomorrow, and I will conclude here, so that's going to be a second high-level event of the NGO committee. It's organized on Rare Disease Day, or even a few days before, but in the context of the Rare Disease Day 2019. This is the cover this year, which is the same photo as the campaign of the Rare Disease Day this year. And it's co-organized and co-funded, I have to say, by Agrenska, Odyssey, and Rare Disease International, including the fellowships to be able to attend and covering some speakers. It's at the headquarters of United Nations, that you know. Co-hosting countries, we put a lot of effort on securing the co-hosting countries. To give you an idea, when we did it in 2016, there were 3 countries, and then 2 which added at the last moment, so we had 5. So this time we have the same 5, which, believe it or not, was not so easy. For instance, Belgium, it took us like a year to get Belgium to, again, confirm. Don't ask me why. And so now we have 15. There is the one that you see here, plus now we had confirmation of Serbia and Luxembourg. So we have 15 countries co-hosting. So that's great. Please. Excellent question. Co-hosting can be several things. What we are asking here is that there is one lead co-host, which is Estonia for the second time. We can say a big thank you to Estonia tomorrow, because when one mission accepts to do it, it's a lot of work. I can really see it. is the logistics. It goes from not only securing the room, but the videos, the translations if needed, everything. I mean, the security is they spend hours. The intranet TV of UN, I mean, everything. So they're really very supportive. Then for the others, what we're asking them is a political support. So there is no funding, it's political support. And then we say, if you wish, you can be a speaker, if you want to commit to the area. And for some, we directly ask them, we say, do you want to be a speaker? Japan, for example, we wanted them to be a speaker. Thailand, we wanted them to be a speaker. So there is some that we've been a bit more pushy, but that's what it means. And we're going to build on that group to create the Friends of Rare Diseases. So we're going to need to extend to more countries. And we will parallel with Geneva so that to build the support. Important for you to know, when a permanent mission in New York is being asked, they just go to ministry to ask like that. But from the moment there is permanent missions of New York and Geneva playing a role, and if in addition for the Europeans, your permanent representation in Brussels to the EU is engaged, then it becomes a transversal priority for the ministry. It's not, you see, the same level. Then they make a decision that through their 3 missions, they will play a role. Excellent. So that goes with my presentation before, but I can then be more specific. Concretely, okay, the question is, how can I get my country to be co-host? How can I contribute as a patient organization to have my country as a co-host? We are writing to the permanent mission, and we ask them, do you want to be co-host of that event? We give them explanation and background documents. Now, the right way to do it for us will be that we send that to you before, so that we write to the permanent mission, and you write to the permanent mission saying, I am the alliance in my country, or I am the Latin federations for this disease, and I would like you to participate as a co-host, and I'm available to talk to you. And then you can have a phone conversation in your own language, understanding your own environment, and you can be very effective, potentially. But on the other hand, we need to know that sometimes it's more difficult to be prophet in your own countries and with the people of your country than to be prophet to others. For instance, for Spain, we work very closely with FEDER all along to secure all the strong commitment that they have in this event this week. That has worked. But for others, sometimes it's easier. For Serbia, for instance, it's because we have access to the First Lady of Serbia. We went through her to go to the permanent mission. The National Alliance didn't play a role because the government, let's say, is not so attentive to them, and the First Lady is not attentive to them neither. But she's attentive because it's UN. So it depends. Does that? Okay. So the royal patronage, I don't know if there is royalist in this room, but I tell you, we have to be royalist, all of us, in rare disease. It's a given. It's a given. For a long time, I was making joke of it. Me, I'm not a royalist. I don't care. I don't want to cut their heads, but although I'm French, but it's not my thing. But I come really to believe that it's great, royalties. You know what? They are stable. They stay around for a long time. When the others, they are elected. Democracy is really a mess. We have always to reach out to new people. Ask Dorica in Romania. They are changing her minister every 6 months. So, and I'm sure it's like that in other countries. But the Queen of Sweden doesn't change. Fantastic. The other thing is that they have clearly a tradition, as we know, of charity and social action. And now in Europe, at least, most of them are now the patron of the Rare Disease National Alliances. So in Sweden, they are the patron of Agrenska and of the activities there. I know that in Denmark also you have often the support of the Crown Princess. In Belgium, we have also the princess. In Luxembourg, she's the patron of the Alliance of Luxembourg, and etc. In Romania, they are not ruling, but there is 2 princesses, right? The 2 princesses supporting. So that's really great. So that's just to say that we have Grande Duchesse de Luxembourg tomorrow as a patron, and we had Queen Sylvia 2016. And what we are working on, I'm mentioning because I'm going to need your contact with royalties. So that's the moment to open your your phone book, is that we are already working on an honorary patron board. You know the Paralympics, right, all of you? There is an honorary patron board of Paralympics where you have royalties plus very few VIPs, which needs to be non-controversial, internationally known, stable, everything. And here we are already in discussions, and Grand Duchess has agreed, and Queen Sylvia and her staff have also said yes. So we will progress, and we will do that in the next months to create an honorary board of different royalties in Europe. But we need also royalties from beyond Europe. So I will not mention names, but we have few in our radar that we are trying to approach through different networks. So if you have some, please come to us if you don't want to say publicly. But we need princesses and queens, and we accept kings and princes also. It's all right. Gender balance will be difficult to reach, but we can try. So tomorrow there will be permanent missions present. So go to look at the list of participants, speak to the people from your permanent missions. There will be officials from the UN. They will come in and out. They will stay for an hour. They will leave. They come back. Permanent missions may be also like that. So it will not be always the same group in the room. There will be some NGOs of the Congo, some stakeholders, and obviously yourself. I wrap up by saying that we have 3 objectives tomorrow. One, which is a given, it's not difficult to win, is just to reaffirm rare disease on the Sustainable Development Goals agenda. Fine. The real goal tomorrow is universal health coverage. So to get rare disease there. So we will have declaration tomorrow of commitments. We've seen them, the draft already, so that's great. It's moving right. And we will call for a UN resolution at the end of the day, based on what has been said during the day in terms of international policy and national plans. So we have the number 2, as I said, of Human Rights Office, Andrew Gilmore, in the New York office. Daniela Bass, who attended last time, in charge of social affairs and social policy in the DESA, so in the Secretariat General of UN. Nata Menabbe, the director of the WHO office in New York. Rudiger Kresch, coming from Geneva, with your lead contact in this discussion at WHO. Pilar Aparicio, that's really generous from Spain. I mean, and that's really, I think, thanks to your relationship and support, that Pilar Aparicio, the Director General of Public Health of Spain, is coming to speak here about universal health coverage and rare diseases. We have also the privilege to have Anders Nordstrom, who is the Swedish ambassador for global health at the Ministry of Foreign Affairs. So he's a key person in the UN system and Sustainable Development Goals. We have the ambassador of Japan, so he's the number 2, he's the deputy permanent, but he has the rank of ambassador. We have the ambassador of Estonia, also of Thailand, who will make a speech on universal health coverage and rare disease. We have Tarek Albani, who is a policy advisor to the Kuwait mission. Satoshi Ezo from Japan mission also, and Ricardo Monteiro from the Brazilian mission in charge of human rights and humanitarian affairs. So we have a good group. All the meeting will be on the UN TV, so all staff of UN can look at it. It will be online streaming, so please say it to your colleagues so that they can connect, they can look at it. Tweet tomorrow, use your Twitter accounts, try to beat the drums of Rare Disease Day and of the event, because that's part of the impact. All the 15 permanent missions will use their social media also, so they are participating to it. It's important to them too. They want to show that they care for that topic. And that's the end. Thank you. Any question, comments? Go ahead.
Okay, so what we'll do, actually, we'll have a chance actually to have some additional questions because these are all related in what we're talking about here. I'm going to just speak to you very briefly, drilling down a little bit more on the universal health coverage and a declaration that we want to have included as part of universal health coverage. So I think, you know, as Jan has really painted a picture, our participation as rare diseases at the global level, at the UN level, at the WHO level, is really a major achievement, quite frankly. When we think about, you know, rare diseases and where we've come from. I mean, 35 years ago, I think, was where rare diseases as a term was kind of significantly coined when NORD, really stepped forward to get the Orphan Drug Act in the U.S. And then after that, 1999, 2000, the EU came in, and even at its inception, the EU made it very clear we need to have orphan drug legislation. We need to be involved in rare diseases. So we've come a long way very, very quickly. I think the brilliance in terms of having the rare disease community come together, to be together, may be obvious to us today because we're living in it, but obviously, but it probably, it was not necessarily that obvious. And quite frankly, it is still a huge challenge to make sure that we all stick together. I mean, we know that if each of us go within for our own diseases and just our own diseases, we're not going to be able to achieve a whole lot. But coming together in this way, we've seen that in the brilliance of the disability community. We've seen that in terms of the brilliance, in terms of the NCD Alliance. Coming together makes a difference. But with rare diseases, we're talking about a whole lot of disease entities. We're talking about, in many cases, very small patient groups being able to come together to have this level of a voice. So for us, this next milestone, I have to say, is almost something that you might not have thought about. If you were to think about universal health coverage becoming a WHO program, and that is, we're challenging all countries, including emerging developing countries with newly formed healthcare systems, to step forward and say, you must provide universal health coverage to your citizens, to your people, and you must include them in some way in terms of health as a right, as a fundamental right. I mean, that's a big challenge. I mean, it's the one that the U.S. is still trying to crack. So there we be. We know the enormity of it. But the enormity on top of it was us as a rare disease community stepping up and say, and as you're bringing this forth, WHO, we want you to make sure that these nations are including rare diseases in universal health coverage. That's audacity. I mean, that's a big deal when you say it, right? I mean, it's not something that one would intuitively think of. Of course we have to include infectious diseases. Of course we have to include, large chronic diseases. Of course we have to be looking out for things like even vaccines so that we can have good public health. But the audacity of saying you must include rare diseases, I mean, that's huge. Especially when we think about the enormity of the task and everything from diagnosis to providing comprehensive coverage and care to providing access to appropriate medicines and treatments. And we'll have more to say on that as we go down the road towards inclusion of rare diseases and, for instance, essential medicines. All those things are critical. I think what's important for us, and all of you will have, is you don't need to read it now, is the draft of a document. So it's still really a draft. We're going to be really not just open for comment, but we're going to be inviting you and begging you to read it and provide comment to it. It's still just a draft. I don't even like the title of it, to be honest with you, Paul, but we'll come back to that. But really, the essence of that title is really important. It says the missing keystone of universal health coverage. I don't know if the word missing is good, but it is a keystone. And don't you know what a keystone is? It's that critical part that brings and holds an arch together, right? And the challenge in here is what we're saying is that rare diseases is actually the keystone, that thing which holds together universal health coverage in your country. That's even bolder. It's not just saying we need you as you're doing universal health coverage to look after us pitiful people here with these rare diseases that are in desperate need of help and support. What we're really saying is that by addressing rare diseases, you're going to really make the difference in terms of how you're actually able to roll out universal health coverage. And there's several important things in there. It fits in with what Jan was talking about and what the overall message is, and that is leave no one behind. So what we're saying is that if you want to really leave no one behind, you cannot leave behind rare diseases, no matter how rare, no matter how small that population is, no matter how critical the need. You must at least be able to consider how your universal health coverage is going to include those. But more importantly, I think we're also saying is that by addressing those with rare diseases, you're actually going to make your universal health coverage work. And if you are able to think about how universal health coverage embraces rare diseases, if the kinds of policies and programs that you're putting in place is conscious of the needs of people with rare diseases, if actually, you're including that, you also will have a much more powerful, effective universal health coverage. Beyond that, we're actually creating another message, and that's as important, is that we as the rare disease community, more than any other community, at least in terms of a broad community, are bringing in a huge amount of resources and support. Nowhere do you have people on the ground that are doing the kind of work in terms of helping to address the need, helping to provide solutions, actually being part of that solution than rare diseases. Sometimes it's a family base, sometimes it's a small group base, but sometimes it's a big international community. Johan was mentioning before, you know, the whole notion of when we have international rare disease communities like hemophilia, like, you know, primary immunodeficiency, all of these are coming in to say, we're bringing in resources here. We can contribute to it. And the kinds of solutions that we've evolved for people with rare diseases, from diagnosis to comprehensive care, to be able to providing kind of supportive care in the community, supporting research and development, those are the kind of things that actually have a huge benefit and impact beyond. And as we know, there's that another small step beyond it, and that is the kinds of solutions that we have for rare diseases, including diagnosis. I mean, genetics would be nowhere where it is today, right, without rare diseases. Think about it. If we had not been thinking about rare diseases, genetic-based rare diseases, so many of these diseases that actually are, you know, the result of genetic, you know, aberrations, defects, we would never have ever, you know, done the encoding of the human genome. If we did not have rare diseases that require genetic diagnoses, we would not have the development that we have. But beyond that, the kinds of medicines that we're developing, targeted medicines that are really specific to genetic variations. That is the spawning of all the precision medicine. So everybody that's living with cancer or any kind of lung disease or any other kind of disease that is the basis of, you know, the benefits from having precision medicines, say thank you to the rare disease community, right? That's us. So I think we have a huge amount to do, including, you know, what I loved in the next go-around was the talking about best practices. And what I heard from some of our colleagues in the rare diseases community is we're not talking about best practice guidelines. That's passé. Best practice guidelines are things that we talk about as sort of averages. It's based on evidence of a 60%, of a 55% best practices, right, Anna? It is not based on individually focused treatments and developments. So you there, unless you're a 60%er, what I'm offering you is of no value. In fact, it may be harmful. What rare diseases says, we need to look at the individual. We need to look at a whole bunch of things that are specific to that individual, not just the genetics, but also the whole context. So again, we're bringing in a great deal here. So I think what we're saying with universal health coverage and the keystone in terms of rare diseases and universal health coverage is that we are all those things. And that's a powerful message for us to be able to say, yes, we cannot be left behind. Yes, we cannot be ignored. And in fact, not only can you do it, but we can help you do it. And in fact, by doing it and addressing the rare diseases, you're going to be doing so much more in terms of being able to provide the coverage for all of the diseases. And quite frankly, you're also going to be embracing our entire community. I mean, who wouldn't want to buy into that, right? This is what we're selling. So take a look at it. I haven't done really justice to it in terms of the details that are in it. What you'll see in here is a lot better language than what I've given you. But look at it carefully. You know, look at it both in terms of what's written in there, in terms of the actual details of it, but also think about it conceptually. What would you like to contribute? And what we want you to be able to do is, this is the executive summary of it, there'll be more to it. I want you to actually feel like, okay, I want to have a document that I can take home and I can use it then to do all the things that Jan's talking about. How do I sell it? How do I go to our governments? How do we go to our healthcare providers? How do we go to our missions and actually say, we need you to buy into this. We need you to support this, okay? So you're going to have to own this. So it's your opportunity and also your responsibility to read it, to provide input into it, because you're going to own it. And for some of you who volunteered already to help translate materials, you're not only going to own it, you're going to translate it. So feel comfortable with it. No, I'm only kidding. But it is very important. So I just wanted to present it to you to give you the opportunity to really understand what it is that we're trying to do with this. And I mean, think about what it would mean. Is that WHO is going to call on all countries to introduce universal health coverage. And what we're asking them to do is say very specifically in there, not just implied in there, not just setting up the language in such a way that it could be, but it says specifically, people living with rare diseases, patients and families. It's specifically included in there, and that's a really important big deal for us. Okay, so that's what we need to make happen. And we only have a short time to do it because, as we know, there's some meetings that are taking place, I think consultations in April, and there will be also, oh, I have slides. Oh, I have slides. Oh, well, this is the definition of universal health coverage. So, okay, you know, it's beyond, as you say, financing is beyond just a minimum package. There's more than just health. I already said that to you a lot more elegantly than Sarah. You got it before, all right? Oh, it's just a great slide about that, Paloma. Okay, this is what we're talking about then. It's under the goal, the Sustainable Development Goal 3, ensuring healthy lives for all. We've already had, certainly at the last 2016, we had a huge boost with the words from Helen Clark. So that was amazing in terms of that statement, in terms of meeting the needs with rare diseases. Yes, we've got the Director General there, Dr. Tedros, who made the important comment for us at the last Rare Disease Day. So again, we're going to be meeting with him. Hopefully we'll be able to ensure that they've got strong support for our inclusion in the WHO agenda and certainly in the universal health coverage. So this is the resolution that was adopted in 2017, establishing 12th of December as Universal Health Coverage Day. I was really pleased to have the opportunity at the 12th of December 2018 last year for us to actually be able to make the pitch at that UN meeting for why rare diseases need to be part of universal health coverage. We were the only NGO invited, and that was pretty stunning as well. So we've got a big step into it already. Oh, that's me. That's me right there at the corner. See that kind of person at the end there? I mean, we really got the commitment of the two co-leads, Thailand and Hungary, who came forth to say, yes, we understand, and we're willing to endorse this. So this is really, really important. And then this is the declaration as we're talking about. So, okay, these are the dates. So there will be a high-level meeting on the 23rd of September. But the 23rd of September is a deadline that's out there. If we wait until the 23rd of December to have this nailed, we're not going to be there. So we got to be ready way before that, right? There's going to be outreach to the members. And again, it goes back to what Jan is saying. We will hopefully be able to help you, provide you with some, you have this, but again, maybe some additional tools if we can, you know, figure out how to make that available to you so you can actually go into your members, your countries to actually be able to make the pitch for why it needs to be included. Definitely Hungary and Thailand are the key countries that need to be addressed, though. In Hungary, we know, you know, we've got a great rare disease patient organization in Hungary. We don't have one in Thailand, so if anybody knows, you know, how we can actually help Thailand, that'd be good. If you might like to move to Thailand and actually start a rare disease organization, we're really happy to help you. No, I want to get it. But it is a challenge because we know in many countries there's not necessarily even been enough groundwork to actually create. And those of you who have created and started, you know, rare disease organizations in your own country know the kind of commitment and work that it takes. But we definitely need to make sure that we're included on this in the universal health coverage. We've got the position paper. There's a full version that's 25 pages. It is worthwhile reading because it provides you with so much of the in-depth rationale for it and the other arguments. But quite frankly, if you memorize this, you're good. Okay, so don't get too excited about it. All of us have gone through university. The cliff notes are all you really need to get by in life, so this is good. Unless you're planning to be a doctor, then you really want to read the entire manual. So for the rest of us, this is fine. Tentative title, as I said, I'm not sure I like the word missing. I like us to be aspirational. It's not missing, because if we say it's the missing keystone, then our document forever says it's missing. We want it to be the keystone. Forget the missing. We're not missing. We're here, we're ready, we're in action, okay? So it is the keystone, and what we're giving you is the position paper is to determine why this is the keystone. Anyway, sharing important commonalities, I don't think I need to put that there. No universal health coverage without rare diseases, and the value of. Okay, ad hoc group. Yeah, okay, so actually this has been very important and really want to appreciation. Kelly Duplessis from Rare Diseases South Africa, Cynthia Magdarug, who's going to be speaking a bit about what's happening in the Philippines, Luciana, obviously Fedopov in Argentina, who's done a tremendous amount of work, not only, you know, with respect to this, but also in terms of pulling together other countries within that LATAM group to contribute to their positions, and Amanda Bulk from the European Hemophilia Consortium. external reviewers that we've actually invited to there, and you can see these are key people that are part of the universal health coverage, and it will then go to the RDI Advocacy Committee, and then so your comments, your recommendations, bring them forth. It will go to the RDI Advocacy Committee, which many of you saw earlier on, and then also then from there to the RDI Council, and then it'll be back to the broad membership for endorsement. All of this has to happen before July, because that's when the final documents will have to be done. And way before that. Yeah, well, July is sort of the drop dead date. So yes, we need to be well before that. So we're looking at April as times for consultation. We're really, really, I mean, I cannot overemphasize how valuable it is to have you on the ground going in and talking to your member representatives. The only people that count in the WHO, the only people that count in the UN are the member states. And the only people the member states listen to are their members, and that's you. So they listen to the people that they're responsible to. So if you're not there, if you don't speak up, we don't have that kind of impact. Nothing happens without that level of impact. And I think that cannot be overemphasized. And as much as we can, from the council point of view, as much as, you know, we know that we stretch Paloma and her staff tremendously in terms of doing this, but as much as we can in helping to support you in terms of your efforts to do this, we will do that because it is so critically important. It would be a tragedy for us not to be after all of this. It would be a huge, huge asset to be able to go back to your own countries after this and say, you must include us because, you know, it's included in the Universal Health Coverage Declaration. So this is critically important. Okay? I think that's it. All right, United Nations. Oh, we will have the World Health Assembly meeting, United Nations in Geneva. We actually have that decidement that's put together. Unfortunately, on the 23rd of May, but we'll make that work somehow. No, it is very important because, again, it's our opportunity to be in front of, you know, the delegates that will be keenly there to make our presence known. So this is a lot of work that's taking place, but I think all of it's recognized for you know, for the future of our being able to have the kind of global policies that will support us. Okay? I'm going to end it there. I don't think we need to take... Is that the end of it? Great. Okay. I'm actually going to move right along, okay, because we're going to run a little tight for time. The next presentation, actually, it's a huge, huge pleasure for me to be able to introduce. I'm probably going to not do real justice to Cynthia's last name, but really, we have been so impressed with the kind of work that Cynthia and her colleagues have been doing in the Philippines in terms of advancing rare diseases as a part of their national health agenda and the kind of progress that's been made. And she says not only getting the political commitment, but actually getting the implementation and funding. So I'm going to invite Cynthia to come up and talk to us about her experience in terms of the Philippines. Thank you so much.
Thank you, Durham. I'm very privileged to speak to you today and to share the experiences we've had over the past year since 1990 to aim for universal health care, hopefully in a few days. So I'd like to cover the milestones and then the patient organization, PSOD's contribution to the passage of the Rare Disease Act, the salient features of the Rare Disease Act, and the provisions on the pending Universal Health Care Act that will impact the implementation of the rare disease. And our continuous claim for our right to life. It's still a struggle, and we expect that it will still be a struggle for several years. In 1990s, the first few cases of rare disease was diagnosed and clinically managed by the Institute of Human Genetics of the National Institutes of Health. The Institute of Human Genetics is the center of pediatric geneticists. There are only 9 as of today in the Philippines. And I asked why. No? Well, Dr. Padilla, our founding chairman, said, because it is not as lucrative as other specialists. But I think with the work that I've seen that they do, I think they are the most noble doctor so far. Okay. We met Dr. Padilla, who was the one who drafted the Republic Act 928. When my son was diagnosed with rare disease, complex disease, was children, and was to collaborate for the effective passage of the rare disease. And these were the National Institute of Health, Food and Drug Administration, the DILG, this is the local government, and the DepEd, and the DOST for research. The Rare Disease Act must have a sustainable feature. And so the PhilHealth, which is the national insurance, will prepare a benefit package for the rare disease. In fact, they're doing it now. There will be fiscal incentives, which covers exemption from all taxes and customs duties for donations for rare disease research, maintenance of registry, purchase of orphan drugs and orphan products. Dr. Padilla considers the two legislations, the rare disease, the newborn screening, and the Rare Disease Act as twin legislations. As of today, we have 6 newborn screening centers and 14 continuity clinics all over the country. So we have 7,100 islands, and can you imagine people living in small islands will take days to go to the nearest continuity clinic to be able to help their child. The Rare Disease Act, which came before the universal health care, will be integrated in the UHC because of 3 important provisions. One, no one will be left behind. The day before the law was passed, many disease groups wanted to latch on to the rare disease because it had funding and it had continuity care clinic. Well, Dr. Padilla said, I think they should do their own program because we only have a few geneticists and specialty doctors and cannot accommodate all the rare cancers or all the blood rare diseases. The other provision is the health technology assessment. This is going to be implemented, and since 2 years ago, patient organizations have been briefed about the mechanics of the health technology assessment. The advantage is that health technology assessment will take cognizance of the fact that the cost of the burden of the disease and its impact on financial, health, and social considerations can outweigh the cost of the treatment for rare disease, giving it a playing field to be included in the government funding. The Act also expands the source of funding. Previously, it was the sin tax. Now, it calls on the Philippine Charity Sweepstakes to provide 45% of their earnings to the fund of the universal health care. Other existing sources of income will now be increased with regards to this contribution to the universal health care. Our claim to our right to life will only be possible if the government, Malacanang Palace is the seat of the government, will ensure the sustainability of the implementation of the Rare Disease Act, and that all stakeholders will commit to collaborate to press for the urgency of the implementation of the Rare Disease Act. I'm very happy to announce to you that last night the Universal Health Care Act of the Philippines was signed by President Duterte. There are a lot of provisions, but I am not sure until we see the actual signed copy. But making the policy is the easier task. The most important is making it work. And that would require the vigilance of the patient organization, participation in suggesting the right policies for them, for the benefit of the patients, and that certain goals, time goals, will have to be committed, because the rare disease patients must have their treatment very soon, otherwise we will lose them. And we have been losing patients because they have been waiting since 2006 for the treatment of their disease. We are almost there, and we hope that someday soon, with our collective help, patient families can feel that no disease is rare for someone you love, because everyone has a right to life and a right to quality life. Thank you very much.
Okay, thank you very, very much, Cynthia. Is there, I know that we're running way over time. In fact, we just came back from break as far as the agenda is concerned. So if you felt like you kind of missed your break, you know, we will indeed have a short break. But just to, I'm just watching hand signals from below. I don't know what she's telling me. Exactly. Are there any questions for Cynthia? I mean, really, it's such an inspiring work that they've done. Very much homegrown work, as you can see, from the ground up, but reaching out to the specialists around them. And I remember asking Cynthia, how in that politically tumultuous environment can you continue doing this? And she says, we just keep our eyes focused on the target, and we keep our eyes focused on the people, our supporters, and we don't have to look up in terms of other things. We don't have to look down. We know kind of where we want to be and the people that are supporting us. So kudos to you in terms of all the work that you've done. Thank you. Any questions or specific questions you want to raise at this moment? Yes? No? Go ahead. Yes.
I just,
yeah, come microphone. Yeah.
Thank you. All right. Thank you so much for your presentation, but also the speakers beforehand. I think the community in itself has done so much coming from grassroots, and myself being somebody born with a rare condition. I came from Germany and have been advocating at the United Nations for the last 10 years in regards to disability, and seen such a big change, and how they keep talking their top-down, bottom-up approach at the United Nations. And I think what the rare disease community has done over the last years and the last decade is really building from grassroots onto this very high political and policy level is just an amazing accomplishment. I think, you know, European Union should look up to you guys and what you're able to accomplish in this short amount of time. And also being a mother and really understanding what parents go through, and oftentimes mothers who have children with rare diseases, and what power is really coming from that, and how you stand up for your child in that environment is just so powerful. And I want to just give, I think the focus has been a lot on health and making the diagnosis better and making life quality better from a medical standpoint, which I think is the most and foremost, most important life-saving focus that we have to have. Another focus that is also within the United Nations and that I see from my own experience is life quality as a whole, which includes not just medical care, but also inclusion in society and being valued as a person. And to really be included in society has so many different levels. And I think that for someone with a rare condition who was told, oh, you shouldn't have children, it would probably be difficult for you and dangerous and all these different things, and being one of the first people to actually go through that and show that it's possible, and if you try. And I know that a lot of families are not sure what can my child accomplish with this condition or cannot. And I think the community on an international level really now, this organization has the power to even grow beyond the medical stage and really support from top down also how to take it further, how to support member organizations in working cooperatively together, how to connect patients internationally to share their stories, to encourage each other on all aspects of life. So I just wanted to make that comment.
Thank you very, very much. And certainly, I think we'll have an opportunity to hear from Lewin, because the relationship and the collaboration with the rare disease community and the disabilities community, I think can really be so much more impactful. And absolutely, there's so much in common there. So thank you, and congratulations also for all the work that you've been able to do and to achieve. I think what we will do then is should we take a break? Is this what we're going to do? Where's Paloma? Is that okay? Can we take a quick break? I know that we're running a bit over time, and I'm not real sure in terms of how flexible, the timing can be. But if we can take maybe a quick 10-minute break and then come back, because then we'll have a chance for Lewin to speak and really talk to us a bit more in terms of the work around the disabilities. And then we'll have 3 quick presentations on what's happening in terms of the regions. Okay, so I think, come back in 4 minutes? Come back at 4. Oh, sure. Come back at 4. Okay, 9 minutes, go. chips. Okay. All right. You going to introduce yourself? You want to do that? Why don't you just go ahead and do that? That's a good idea. Okay. Go for it. We're going to get people back in. You get ready to start. I'll go round people up. How's that?
Hello? No? Test. One? No? It's okay? Oh, there we go. Good afternoon. So we were ahead of time, and after the break we are behind. That's what a good conference should be, I guess, that you run behind in coffee breaks. So my name is Lieven. I'm Secretary General of the International Federation for Spina Bifida and Hydrocephalus, and I got involved in the rare disease community a couple of years ago because for people living with spina bifida and hydrocephalus, the European policy on rare diseases became increasingly more important. And when I got involved in the rare disease community, I felt that there should be a bit more emphasis on combining the rare disease community and the disability community, because they were kind of operating in two different spheres. And it's they're two distinct, in a way there are two distinct policy communities. They're the same people, but they kind of work in different areas. And then Euroris made the decision to get a bit more involved in the human rights approach, and that's when I applied for the put myself forward as a candidate for the board of directors, because I hoped to help them move into that direction. And so I'm going to talk a bit about the UN Convention on the Rights of Persons with Disabilities. The problem preparing for this talk was that I had no idea what the level of understanding would be of the Convention on the Rights of Persons with Disabilities. So if it's redundant talk, then I apologize, and you can tell me, and then we move a bit quicker. If there's something that I go over too quickly because I only have 15 minutes, then you just stop me, okay? So this, of course, is also an opportunity for me to talk about my organization, so I'll do that. I have to. And then a very, very brief introduction on the CRPD. And I would just like to give one example on how to use the CRPD. Now, Jan said in one of the previous lectures that the UN Committee for Rare Diseases is our little boat in which we navigate the UN system. Now, a country and policy in a country is like this big tanker that is not moving very quickly. So we, with our little boat, we can probably move very quickly, but this tanker is not moving very quickly. And the UN is like this bunch of tankers stacked on top of each other, and nobody really knows who's steering, and they just kind of and it doesn't move very quickly at all. So the example that I'm going to give on the right to health will show you how slowly this tanker is moving. The CRPD, the Convention on the Rights of Persons with Disabilities description, will show you how slowly this tanker is moving. And so maybe the ideas that are forming in our heads on the policy that we try to achieve at the UN, let me assure you it's not going to happen tomorrow. So it goes at very quick speeds to UN standards. So we have to be patient and very persistent. And I think that's a lesson that the disability community can definitely provide. Anyway, the International Federation has 65 members in about 60 countries. You are all familiar with international federations and what they do and what their mandate is. Just very, very briefly, oops, where do I point to? Oh, there we go. Spina bifida is a neural tube defect. Actually, spina bifida is one of the many neural tube defects. It's a birth defect. It's important, that concept. It's when the neural tube, when it's closing, is not closing properly and you get a defect. That's spina bifida. It's related to nutrition. Hydrocephalus is connected to it, but it's a bit different. It's when the balance between the production and absorption of cerebral spinal fluid is distorted. You get a plumbing problem in your head. And it has all kinds of consequences. I'll leave it at that. Now, the problem is that the perception of birth defects all over the world is it's kind of like this. It's either like this scientific drawings. This is not working very well. It's like scientific drawings. It's a horror picture. That's what people show, and it kind of reinforces negative stereotypes. And this is for spina bifida, but I guess in the rare disease community, it's very similar because it influences the way people approach a disability. So when we talk about spina bifida, these are the pictures that we show active people. You know, in order to design policies, you actually have to care about the people you design policies for, and that's why groups of representing the people with spina bifida or with disabilities have to be directly involved. So that was briefly about my organization. That was not too bad, was it? No. Anyway, the CRPD, the Convention on the Rights of Persons with Disabilities. If you go online, I put the link in the presentation. I don't know if you have access to the presentations. Here's a link. It will give you a book with the history of disability at the UN level. Because it's a long history of 70 years developments. It started with the first mentions right after the Declaration of Human Rights. And then there was a whole process with a declaration in the 60s and a declaration in the 70s. And then in the 80s, they had the Decade of Disabilities. And that led up to the starting of the negotiations for the CRPD in the beginning of 2000, with eventually the CRPD adopted in December 2006. So it's been 12, 13 years. But the big shift was that within the convention, it says nothing happens about us without us. And you can find that in two distinct articles where it's explicitly stated that people with disabilities, like we talk in this community, people living with a rare disease, people with disabilities should be involved at the design, implementation, and monitoring of the policies. And the advantage of the CRPD is that it's not like a resolution where it's non-binding. The CRPD, once it's ratified, it's a binding legal document. And because it reaches almost universal ratification, almost every country has ratified the CRPD, it gives a legal instrument for changes in policy in your country. Because that was mentioned before, all the activity, all the action actually happens at national level. It doesn't happen, not necessarily, and especially not in health, at the international level. It happens at the national level. And the CRPD then it's one of those instruments that you can influence policy at national level. So when it comes to monitoring of the convention, there are three bodies that we can talk about. And one is called the Conference of State Parties to the Convention on the Rights of Persons with Disabilities. The second one is the CRPD Committee. And the third is the Special Rapporteur on the Rights of Persons with Disabilities. The Conference of State Parties is the General Assembly of the CRPD. Every party that signs the convention comes together in June. So this year is going to be the 12th session. And they meet the 10th to the 12th of June here in New York. And they, according to the convention, they meet regularly to consider any matter with regard to the implementation of the present convention. Actually, it's kind of a political talking shop. That's the Conference of State Parties. The important monitoring tool that we have is the CRPD committee. Now, the committee is a group of experts that is in the office, that's housed in the Office of the High Commissioner for Human Rights, and they review how individual countries implement the convention. And then there's a special rapporteur who's appointed by the Human Rights Council to monitor and promote the convention. But I'll come back to that later. Now, the good thing, because it's mentioned in the convention that it's nothing about us without us, NGOs, representative organizations, actually have very good access to those three bodies. Like it was mentioned before, Clara was able to make a statement on behalf of RDI during the Conference of State Parties. Now, this is what happens. This is the process. So every 4 years, a state has to submit a report to the committee. The committee reads the report, I'll just take the other slide. The committee reads, so the state submits the reports. Civil society is allowed to submit a shadow report, give extra information to the committee. Of course, the state will say, look at all the things that we do for disability, right? We are great. And then civil society says, well, there's a somewhat more nuanced view. Here's our report. The committee reads it, and when there's issues, they make the list of issues. It's actually called the list of issues. The state then has the opportunity to respond to this list of issues, and then the committee meets. They meet twice a year for 14 days, and they review like 30 countries. And in that meeting with the state, they have discussions about these lists of issues. When they've discussed it, the committee drafts a report. It's called the concluding observations, and that goes back to the state. And then, of course, 4 years later, the state has to make a new report, submit a new report, and the whole cycle starts again. So this is the tanker, right? It takes forever. But the advantage is it's a legal document, the convention, and it's written down what the issues are with that specific country. So I'll just give an example. The example is coming. First, the special rapporteur. She has a lot to do with a very small team. But again, the thing that is important, and that's all already achieved, are her annual reports, because she has to report once a year to the UN General Assembly, and in that report, we as civil society, she makes the reports, right? But we as civil society actually have quite good access to her when she's making the reports, and thus that's what happens in May. I'm not quite sure about the order of the slides here. I'm sorry, but she had an expert meeting on her reports and the access to health, and that's where Paloma went, and then eventually, you saw the slide already. There was the mentioning of rare diseases in the report of the special rapporteur to the UN General Assembly in October. And so again, this is another drop, another stone in the river, just to build on the case for rare diseases at UN level. So specific case, right to health. I'll just go past this one because I don't know how much time I have left. Not very long, I guess. So the article, this is the article on health. It's a very long article. And so you see, I'm not going to read this. You can all find this online, so you can, if you think this is important, you can just search for the article. so this is in the preparation for the, that's what I said about the special rapporteur, that there was this expert meeting in Geneva where Paloma also attended, I attended, and then eventually it ended up in her annual reports to the General Assembly. So when you look at a country, right to health means different things in different countries. For our case, for children with spina bifida and hydrocephalus, when we talk about the right to health care in a developing country or a low-income country, it means a very different thing than what it means in Europe or in a middle-income country like Vietnam. So the state that we're going to review, the party that we're going to review in this example, is the European Union. The European Union, as a regional entity, has also signed and ratified the convention, so they're also up for review. And so when we talk about Europe for spina bifida, because that's all, you always have to keep the party's reality into account. We talk about a region with a high income primarily, and the needs, the healthcare needs for people with spina bifida in this case, in that region, are different from the healthcare needs for children born in Uganda. I was able to visit our members in Uganda. They're here. The need for children with spina bifida in Uganda are, we need to have access to the very basic first steps of healthcare, not the more, the more complicated and multidisciplinary issues that are happening in Europe. So this is the slide of the intervention again. So we'll just go through a practical example. So the European Union submitted their first report to the committee in 2014. And on health, I don't remember the exact wording, but this was in the list of issues of the committee to the European Union. They asked for a bit more clarification. The Commission answered by saying, well, there's different competences between the EU and its member states, but we promote the exchange of best practice, and we will do some pilot projects. I have no clue what the pilot project is about because I don't think they ever did it. And then in 2015, these are the concluding observations here. This is important when it comes to health. It also recommends that the European Union evaluate the impact of the European Parliament and the Council directive on the cross-border health, which is important for rare diseases, and look at the gaps in access for persons with disabilities, accessible information, reasonable accommodation, and the training of professionals. So now, the next cycle in 2019, they're delayed 2020, 2021, we as NGOs have to look at whatever the Commission, the European Union as a whole, promised to do, and we can then evaluate. And the whole cycle then starts again. Okay. Thank you. I hope this was not too dry, but we can discuss about this for 15 more minutes.
Maybe not 15, but a few more minutes.
Yeah, it's an independent expert. I think it was yeah.
From Guatemala, and spina bifida is not a rare disease. So what happened with countries that are not complying with that is, I don't know if they send the reports, and even if they send the reports, I don't know if or I don't know the case of Uganda, but how they respond and how are they, I don't have the word, how can you assure that they are doing something in order to
but that's a
comply?
question with, yeah, that's a question. So first I want to respond on the spina bifida is not a rare disease. You're right when you when you think about incidence in affected pregnancies, then you're very right. But the definition for rare disease is not on affected pregnancies. The definition is in the prevalence in society. And in countries with low income, there might be a high incidence in pregnancies, but because of a very high mortality and the lack of care, the prevalence in society is a rare disease. In Europe, most of them are diagnosed prenatally and aborted, and they might have a very good chance of survival once they're born, but only 2 in 10,000 are born, which is way below the thresholds of 5 in 10,000 for rare diseases. So the legislation on rare diseases is important for this community, even in Guatemala. Yeah. Maybe Guatemala is the only exception in the world. I mean, I cannot really comment on it because there's some other issues that are playing there. But still, of course, if a country is so cynical that they're not submitting a report and not taking into account the recommendations, it's very hard to change any policy anyway. I mean, if there's a dysfunctional state, then there is a dysfunctional state. And I mean, you could say, well, you know, the CRPD committee does not have a lot of impact in Congo. Yes, that's true. Yeah. But in Uganda, for example, there is civil society and things are moving, and they're not necessarily moving quickly enough, but they are moving. And this gives you kind of a hook. You know, it's. But you know, if one's cynical, then of course nothing changes. Yeah.
What is your definition of disability?
Please use the microphone because it's being live streamed. So.
What is the definition of disabilities? I think in our country there's only 7 categories: sight, hearing, or it's only refers to physical disabilities.
I'm going to refrain from commenting on that, yeah, because it's a really difficult. That's actually a very difficult question, and they're at this moment debating this in the disability assessment because it comes with certain rights, I guess, and that's a very, very difficult question.
Because rare disease, disability is due to a medical condition.
Yeah.
But when you want to apply for it, they don't look into medical. They just refer to the physical. Because someone has skin disease, they are not under disability, but it's rare. And then now you're talking about education. And so these are areas, do we need to change definition of disabilities to include, maybe those days, rare disease was not known at that time.
Yeah.
Physical. So this is my issue.
I was going to say maybe there's somebody in the audience that wants to comment on that question, and I see that KP actually wants to.
Wait, I'm coming. Here you go.
Okay. Thank you. Since I'm also the convener of the CRPD committee in Hong Kong, so may I give some comments about the definition of disability. As to CRPD, disability doesn't mean the body structure, functional defects of a people. The disability is happened when the people interact with the society. Likely, a wheelchair user, if he doesn't interact with the society, that's no problem. But if he goes out everywhere to receive education, to seek for employment, that's the problem. So the disability should be, as my perceive, is the society's disability, because the society cannot accommodate every people, including those with body structure defects, with functional defects, or with sensory organs defects. So the disabilities happen when people interact with the society, not really the people themselves.
Thank you. Yeah, it's a good definition, but the practical implications are vast, and the whole discussion on disability assessment is ongoing, and will. I mean, there even on how to measure disability in specific countries, the incidence of disability has been a very, very difficult discussion between different stakeholders. So.
Yes, I want to add that it's correct what he said. The disability also couldn't be visible. The problem is that the disease is the way that the function that the people had to do in the society affect the diagnosis they have. It's not the disease, the name of the disease, the disability. The disability is when the people have to interact with the society in different way, so they have a different way to act the function that the disease caused to him. Mm-hmm. So that's the definition of disability.
Yep.
Just do one more, because we do have to close off.
Yeah, there's the Washington group questions that are being discussed at UN level all the time now in regards to disability. So I think it's like 5 short questions, like kind of assess if you have any difficulties with participating in society, and that's how they're trying to determine if somebody has a disability. So if you want to look up the Washington group questions for census, might be helpful.
So even that is controversial.
Yes.
Okay. Because it's a functional approach to disability, and if you're born with a disability, so what they do is they use surveys in order to see whether, what part of population has a disability. And I think it's really important to have a view on that. But a survey is a methodology that does not allow for diagnosis under a certain age. So their cutoff age is 2. So they measure childhood disability at the age of 2. And of course, when you're born with a disability like spina bifida, I don't know how for other disabilities, other congenital disabilities, it's probably very similar, and there is no care. Most children born with these disabilities will be dead by the age of 2. So there will be no policy supporting the children born with disabilities. And so one of the things that I've been fighting for is for a better, and that was 3 or 4 slides on data, was actually better measurements of disability of children born with disabilities, because it's a forgotten group in whole this. And I think this is very relevant for rare diseases as well, because of the congenital aspect of it. So for me, they're very controversial, and also for WHO, who's the agency that is holding the monitoring of the convention for the UN. They have a different approach to measuring disability, and there's some controversy there as well between WHO and the Washington group. Yeah, so it's difficult.
Okay, so we really need to end this part of the discussion, so we can come back to, I think, some additional comments here. But thank you very, very much, Leland.
Thank you.
I mean, as we say, it's not just the overlap between rare diseases and disabilities, but it's also what we can learn from what the progress and the advances and also the struggles that the disabilities community in advancing, certainly with the convention as well for us. So this, I think, has been hugely informative. And I'm sure we will continue to move together as we're going forward. So we're going to, we are pretty much back on schedule. So I think what we'll do is we've got 3 very brief, I think, presentations around regional alliances. And again, as the Rare Disease International, we are made up of member organizations, national alliances, and international rare disease groups, but we're also very keen in supporting and working with regional alliances, again, because it will allow for there to be that level of policy work, but also sharing and support in a region, and it also will allow us in some ways to be able to work, I think, much more efficiently. So Ritu Jain, who's the head of our Asian Pacific Alliance of Rare Disease Organizations and also on the council of RDI, was not able to make this meeting. So in her absence, I am going to present a brief update in terms of the Asia Pacific Alliance of Rare Disease Organizations. Who we are and what we do, okay? Well, that's pretty straightforward. So the background. I think just to say that, obviously there's disparity and there's differences across all regions. The Asia Pacific region is actually quite interesting in terms of certainly orphan drug and rare disease policy. We can see that in that region there's a huge range in terms of economic and political development, from including in there is our countries like Australia, which are extremely well developed and quite well advanced in terms of political policy. Japan, which again has a long history also in rare diseases and orphan policies. And then we also have China, which is a huge country and has actually created many other initiatives more recently. And then we have obviously the very small countries, many of whom are not actually even represented in APARTO because they are small. As I was mentioned earlier, our challenges with Thailand in terms of embracing universal health coverage, with Thailand as one of the co-leads, is that we don't actually have an alliance of rare disease organizations in Thailand. I think we've got countries where Cynthia's given us a brilliant presentation around the Philippines, which actually has been able to do a great deal, I think, despite some of the challenges, both economically, politically, and service-wise. So there's a huge disparity there. I think there has been, of course, a great deal of cross-fertilization participation in other kinds of forums, and there have been other networks that have been put together. What we wanted to do in that region was actually talk about a collective patient voice. And part of that is not the same as the EU, obviously, where one could hope that you would have a policy that would actually span across the countries, but one is that for countries to be paying attention to each other in terms of what the policies are and hopefully learning from each other, the patient groups to be able to share and support and to leverage the work and initiatives of the others, and also then into the future maybe some ability to have cross-border kinds of services and support, whether they be in terms of diagnostics or whether they be in actual centers of support and excellence. We have been coming together in the region, I think, for a number of years. October 2012 was kind of a significant meeting where patient advocates came together to talk about their common challenges and the possibility of a regional collaboration. We actually officially came together to agree that we should, and there was value to forming an Asia-Pacific Alliance in 2014. We met in Shenzhen, which will actually be where the Rare Disease Accord, Chinese Organization of Rare Disease, will be hosting a meeting again. It was a fairly fortuitous time because I think there was an international meeting at the time, and there we agreed that there was value in terms of establishing the alliance. And then in 2015, we actually then officially set up a nonprofit organization. Only 7 founding board members. There were only about 20 people that were in attendance, but it was an opportunity to actually forge an agreement to actually work together and to collaborate. And then last year, in 26, 27, 2018, we established a meeting, established the organization, and quite frankly, it fell dormant for a good for that intervening period of time. It was difficult in terms of leadership. I think there were lots of different kinds of regional activities taking place, but nothing that officially came together with the goal of advancing more regional policy, with the specific goal of being able to collaborate in the same way around the sharing of resources and development. 26 to 27 October was actually an opportunity then where a number of us that had been part of that seminal group decided that it was opportune to bring together and try to host and renew the initiatives of APARTO. And part of that was actually due to another initiative, and again, it's taken advantage of something that was happening in the region, and that was the Asia-Pacific Economic Collaboration, which actually was creating then the framework for Rare Disease Network. So I'll come back to that in a second. So this is kind of our vision. I don't think it's different than what many other people would say, to a strong united voice. And again, the reason of a united voice is not because there's a single governance structure, but the fact of being able to create a greater presence that others could call on to help each other to work towards the improvement of treatments that would allow for better access and funding. And again, the notion of having a larger voice in the area. And again, many of these organizations already participate in Rare Disease Day, already participated, many of them as a member of even Euroris at the time, and recently some joining RDI. But again, recognizing that a strength in a region could actually help to foster better policy development at national levels, and also hoping to foster other national alliances. This is our current board of directors. So Ritu Zhang, who is in Singapore and is head of DEPRA Singapore, is the president. Bill Claxton, who's with carcinoma endocrine tumors in Singapore, is treasurer. Ramaya Mutayo is secretary. And then there's a number of others that are board members, including Fiona, who's from Australia, and Kevin Wong from Chinese Organization of Rare Disorders. We're delighted that we've actually hired a staff person who actually can help in terms of keeping communications and providing the coordination that we need. She's also actually quite well versed in terms of policy, so it's an actual added bonus so that she can do a great deal more than just some of the administrative work. But again, these are the initial members. There are some additional people that are organizations that are not yet into the membership list, only because we've not quite restructured in terms of how to include new members. And again, from, as you can see, a variety from across the region, from Australia to China to a couple of the organizations in India, Hong Kong Alliance for Rare Diseases, and also then 2 affiliate members who are based in Singapore. Really, as I said, one of the opportunities for bringing together, and we're hoping that this will actually be a part of the impetus to moving forward, was in fact the Asia-Pacific Economic Coordination, which actually came together to actually hold a summit that actually then approved and launched the APEC Life Sciences Innovation Forum Rare Disease Network. And tomorrow, we'll have an opportunity to have a brief presentation on that and some of the other work from Matthew Vilgard, who is actually the co-chair of the APEC. I actually should let you do the rest of these slides, but I won't put you on the spot. He's just flown here after some 30 hours, I think, en route from Australia. So we're delighted to have Matthew here. Thank you very much for all the work that you've been doing in terms of making this happen. And we've had a couple of discussions around it already yesterday as well, Matt. So I think there's a lot of interest and excitement way beyond even just, that initial Asia-Pacific area. I think there's lots of opportunities for us to think about how we can use the framework and how we can actually use hopefully, some of the initiatives that will be coming out of it. It's an action plan that outlines 10 key areas for action to tackle the challenges of rare disease, not too different to those of you, in Europe who've actually developed national plans. The key areas of strategic areas for addressing rare diseases, including, obviously you can imagine, diagnosis in terms of multidisciplinary comprehensive care, support communities, etc. What is really, I think, great about the action plan is that it envisions the ability for countries at many different levels of economic and other kinds of political development to actually take part in it, but also it provides then some core standardization around what are the key elements that, not to say this is the be-all and end-all, but I think as many of us know, there are many, many countries that have developed national plans and national strategies, and they may address only 1 or 2 key areas. And that's not to say it's not a great start, but this actually lays out then what are all the areas that should be at least considered if you're going to have a comprehensive national plan for rare diseases. It calls upon all 21 member economies to improve the economic and social inclusion of individuals living with rare disease with targets that they can identify by 2025. And a part of then, as a result of, its ability to actually come back together as a patient organization, having a presentation at our meeting in Singapore, has been invited to be a regional partner there. reinforcing, I think, the value in terms of having these regional alliances as well as being able to take part in an international alliance. So we're very excited about the opportunities. We're really looking at using this APEC framework as an ability to actually help member organizations, the same as we talk about what might be happening at an RDI level, to develop some of the global connections and policies that will help patient organizations to call upon their governments to provide certain kinds of sets and services. This actually is a bit more strategic and action-oriented in terms of what it is that we would like to see happen. I mean, ideally, one could think about the 10 areas and the action plans, look at the key components of it, and even do an initial inventory to say, you know, within their country, where are we now? What is the current status? And then what could we actually aspire to in terms of the next set of years? So next 5 years, next 3 years, next 5 years. So it provides an ability to do a benchmarking as to where you are now, and actually then set, you know, relevant goals within that country. It also is hopefully an opportunity to be able for the patient organizations to call upon their countries to engage more specifically around key areas, or to build on the existing expertise or resources. Again, we anticipate it could vary considerably among the 21 countries, and nobody is expected, I think, to achieve all 10 goals to their completion by 2025. I think my initial challenge back to APEC at the time was that these are highly aspirational, and the answer I got back was, yes, they're meant to be. So there we are. It's a very aspirational approach now, but I guess if you don't aspire to it. But it is nice because it does have very specific, tangible actions that can be taken, and that organizations, stakeholders, industries, governments, clinics, hospitals can all take part of. I love the fact that, in fact, it's a highly multi-stakeholder, multidisciplinary group that came together in terms of the creation of the framework, and actually have put, I think, real work in terms of making those actions that are quite meaningful. I don't know if they're feasible, but they're definitely meaningful to each of the stakeholders. This is the economic cooperation. Interesting enough, 21 member countries, as we said, and as you can see, ideally they're countries that have a Pacific coast. So they're on both the Western Hemisphere and on the Eastern Hemisphere. They're in the Northern Hemisphere and then the Southern Hemisphere. Interestingly, as I say, almost your two biggest countries in there is Russia and Canada, at least geographically. So, you know, we're kind of, it's an interesting mixture of countries, as you might say. And then you've got Australia, which again, as we say, is very developed, China, and then some very small countries, including, you know, Indonesia, Singapore, Malaysia, Thailand, Vietnam. Vietnam and the U.S. actually host the summit meeting that actually helped the formation of this. It was very interesting having one of the biggest countries and one of the littlest countries co-host this as a joint meeting. In the Western Hemisphere, we not only have the U.S. and Canada, but we actually have, interestingly, 3 of the Latin American countries, Mexico, Peru, and Chile. Some of the other countries, you know, are not members of APEC, is all we're saying. It's Colombia. It's one of the biggest countries, which is not a member of it. And what we really want to say is, regardless of whether you're an APEC country or not, we're hoping that there will be relevance as we begin to move forward in terms of developing some of the, hopefully, tools that not only other stakeholders, but also member organizations can use in terms of helping to advance the APEC framework there. And some of the other stats on the side, 2.8 billion people represented. Almost 60% of the world's GDP is nested in these countries, but it's also responsible for about 50% of world trade. And so these are the different aspects of it. The vision is that economic members will, EC members, economies will aim to improve the economic and social inclusion of all those affected by rare diseases by addressing the barriers to healthcare and social welfare services. And 3 very specific objectives: greater alignment of domestic policies and regulations towards support for the vision, support urgent implementation of proven best practices, which is actually quite I think an important notion. It's not necessarily developing and redefining what are the best practices, but how do we use best practices to bring them into different sectors, and then promote multi-sectoral collaborations and patient partnerships. This is just the signing of the declaration. No, there's Matthew's signature right there in big letters. Hey, there we go. You know, if, we could probably pull it off and he can autograph it for you personally if you wish. But it is very important. We are very excited about the creation of this, and certainly I think excited because it really does, you know, bring in, I think, many sectors, including the emphasis of rare diseases as an economic instrument, as an economic good, and really hopefully harnessing some of the economic organizations to actually take part in the realization of rare diseases. So at the one hand, we've done what we've been talking about, the UN and the WHO, in terms of the global, you know, social, societal supports and the health community. And in this case, we're also including within there, what can we do from an economic perspective? What do we need to harness from the genuine perspective of the economic? So I think and again, it includes social and health and as driving factors, but it really does bring in, I think, an additional element. And, you know, we really, I think, see it on both sides when we look at some of the objectives there, that rare diseases is not necessarily an economic drain, but rare diseases can actually be an economic engine in many respects in terms of country development. So this is really a great opportunity to look at it beyond that. And I think that might be it. Okay. I think we'll just do the 3 presentations, and then maybe if we can, we'll take a few questions at the end. Is that okay? Unless somebody has a burning question around APEC at the moment. Okay, so why don't we, I think we're going to have a presentation from Kelly, who's going to talk to us about the work that's happening in the Rare Disease Alliance in the Africa region. I think many of you will know Kelly Duplessis. She's been the founder and the driver of rare diseases in South Africa, but also has been brilliant in terms of some of the work she continues to do in terms of spreading the message well beyond. So thank you very much, Kelly, for making the trip all the way over.
Thank you very much. So firstly, your weather. Coming from South Africa, we're taking a bit of a beating here, Ida and I, as the only African people. So just a little bit of background. I'm the founder and CEO of Rare Diseases South Africa. I started out of personal need at the diagnosis of my son with Pompe. And similar to, I think, most stories driven by that personal need to have to make a difference, that puts you in a pot of boiling water that you really have no idea how you got into or how to get out of. So here we are. So Africa Rare really was an initiative that sprung about in 2016. We hosted the first RDI AGM and also the ICORD meeting. And really, I suppose Africa does things their own way. We're famous for African time. Everything runs a lot slower. And having been a member of Eurodis for some time, realized that we needed to have our own set of rules. We were playing essentially on a different playing field. So it was, how do we take the knowledge that has been implemented in other parts of the world and really make it our own? And that is how Africa Rare started up. So the aim of Africa Rare is to create a common voice, to advocate for patients' rights to treatment, ensure that no patient is left behind. That phrase really came about in 2016, before universal healthcare was such a hot topic where we are. Creates awareness and raise the profile of rare diseases, and to ensure members have access to effective communication, up-to-date information, supports and networking opportunities. I mean, that last point there seems relatively obvious when you take into account that many people that from where we come from do not have access to internet. We in South Africa have 11 official languages. Just finding a way to communicate with patients in itself is quite tricky. So we currently have 11 members, 11 member countries, and all of us are at various phases of development. Some of us are quite far ahead in comparison to others. And then I come over to meetings in Europe and here in the States, and I realize just how far behind we are, and then I go back feeling a bit depressed, and then we come back and we try again. So this picture was taken at our RareX conference last year, and I'll walk you through a little bit of what we did there. But we had a capacity building meeting after the conference had closed. And really it was an opportunity to understand from patients, healthcare professionals, patient advocacy organizations, exactly what challenges they were facing. So we did what was essentially a relatively classroom-style exercise. And it wasn't starting with what the problems were. We asked, what do we want? So those were all the little pink pieces of paper. And we asked everybody, write down 3 of the most important things that you want. And we took it from there and then we said, why is it that you want them? What are the problems stopping you from getting them? And those are the blue pieces. And from there, we just realized that there was really 5 focus areas, and these have now formed what we are putting into our strategy. And the 5 focus areas were data and surveillance, support and stigma, info and awareness, education and policy development. So from there, we developed sort of a 1, 3, and 5-year plan of things that we found were really, again, leading towards what our wants were. And there were 2 other sections to this, which I didn't include here. One was disease-specific groups, because obviously as a disease-specific entity, you have different things to sort of global issues. And the other was as national organizations. But as a RD coalition, in terms of education and training, investigating online platforms, conference, podcasts, Meditalks, those sorts of things, again, seems like simple problems, but really we don't want to reinvent the wheel. In terms of implementation of online training platforms, we in South Africa have 12 geneticists out of a population of 56 million. If we can find appropriate training that is easy as logging onto an internet, great, then let's use that, as opposed to trying to make sure that universities and stuff are upskilling. Let's try to find an alternative way. Continuing online training and updating content every 4 years so that it remains relevant. In terms of stakeholder development, engaging with funders regarding education, materials, palliative care and congenital disorders. Palliative care is so critical. I think it's something that we often forget about as patients. We all deserve the right to die with dignity or live with dignity. So those are policies that are really being pushed in our area, and we've tried to latch onto them to make sure that we're not excluded from them. Release and dissemination of better care palliative care training manuals, and then the 5-year plan was translate these policies and books into manuals in relative languages relevant to Africa. In terms of info and awareness, the first 2 things were creating centralized online hubs for information. And again, it's sometimes such a simple thing. At the moment, we're using like a Google Drive. I mean, it's not reinventing the wheel, but it's just such a practical tool to make something that much easier. In terms of stakeholders, it was to do a fact find of what toolkits currently exist. If we can approach an organization who's already done it and ask them if we can use what they've done to adapt, then it's the easier and the quicker way. The 3-year in terms of the Rare Diseases Alliance is to create and set up crowdfunding campaigns. Again, because we as countries really battle with funding. And it's not getting any easier because we don't have data, which will lead to the next point. So we thought, what was the best way for us to get some money together to be able to start doing what we want to do? Ask the people who we're doing it for. The 5-year continue online training and updating content once again. And with stakeholders, it's to link to African unions and other major partners, etc. Everyone here, we all know we're talking about the United Nations. I can tell you in South Africa, the only thing that matters is what the African Union wants. And it is really, really challenging for us because we are members of the United Nations, but it has no teeth unless the African Union has bought into it. So that is a really big drive for us. In terms of data and surveillance, we need to identify common needs between groups, developing of a generic registry model. So it doesn't necessarily mean that everybody has to reinvent the wheel. If we can develop a framework that every country can then go on to adapt, it'll make it that much easier. Registry workshops. I tell you, having a registry is one thing. Finding people who understand how to use it is a completely different story. And one of the major challenges that we have is that none of our healthcare professionals are willing to actually input into the registries because they say it just takes up too much of their time. So unless you can find people to administrate those registries or find a way that makes them relatively easy to access, we might as well not have them. In terms of stakeholders, it's to identify relevant stakeholders and meet with the people that hold the data and that need the data. Because there's no point developing information that no one really wants. It's important to understand what data needs to come available for us to be able to give them what they need. Right, then in terms of support and stigma. So, and this is a really, really sad reality. A lot of our ethnic beliefs in Africa revolve around, there's a lot of cultural stigma around short stature, disability, dysmorphic features, etc. We've got kids that's parents literally don't let them out into the daylight. These children only come into hospitals in the dead of the night to receive any form of access to care. Their family members do not know that they exist. That is how bad the stigma is in South Africa. And it is much the same for the other African countries. So for us, support and stigma is such a huge barrier. So we want to create a directory of groups available and to identify barriers and brainstorm on how to develop processes around that. One of the biggest, we have a lot of traditional doctors in Africa, and 67% of the South African population goes to a traditional doctor before reaching out to normal healthcare professionals. 67%. If we're not accessing those traditional doctors, those patients will never know that we can assist them. So we really have had to sort of think out the box and sometimes just be very down roots and sort of grassroots to actually get to what we need. Developing funding calls to action and awareness of services of palliative care, once again, comes back to dignity. Developing a methodology and framework for genetic services is meant to be GS. And can also, in terms of running that palliative network, the access should be there. We just actually need to make sure that it's implemented. And in terms of policy development, this is my thing. I sit on the policy side. So it's really just about introductions. That's the first thing we needed to do. We need to know who's doing what. Jeraine, you were saying that there's no one in Thailand. I'd go to Thailand. So, I mean, sign me up. But really, you know, just in having these sorts of meetings and these sorts of discussions, Eden now has someone to phone. Our country in Kenya has someone to phone when they're having an issue. And it starts off with that simple networking. One of the major challenges is definitions. It was discussed briefly here earlier. How do you define the problem when you can't define what goes into that problem? If you're using a phrase rare diseases, but as a area you haven't determined what a rare disease is, how then do you know what gets included and excluded? So that is a major challenge that needs to be addressed. And then political change and available funding from a policy level. So South Africa is currently moving towards universal health care. It's moving towards national health insurance, which is based on the premise of universal health care, but the white paper that's been released doesn't look anything like universal health care. But with that, an opportunity came about to sit on the sort of group of individuals that are inputting into that. And it's to discuss now the associated budget. You don't actually realize when you're complaining about things, the amount of thought that has to go into every level to actually get the budgets approved. But one of the things that I think we've been instrumental in helping our government realize is that we are here to help. As a community, we want to help you make a difference. So our approach has been very solution-orientated. We haven't gone in there and said, you're doing this wrong, or you haven't done that. We've said, look, we can help improve this by doing X, Y, and Z. We need you to do A, B, and C to be able to get it there. And that approach seems to be working. Now we hope once that South Africa's adopted it and it starts moving through the rest of the African countries, that we would have developed somewhat of a framework for them to be able to use. So yeah, that's just us in a nutshell from little old Africa.
So does anybody have questions for Kelly here? really impressive, I think, when we were in South Africa for the ICORD South Africa meeting. I think there were a small handful of organizations, and I think we're impressed in terms of your ability not only to continue the work that you're doing, but bringing in others and really providing that inspiration. Kelly is that real example we talk about, right? It really takes an individual to go out there. I'll give you 6 months to learn Thai, and then we'll ship you. You think you can do that? Any other comments? Yes, Matthew.
Kelly, really...
2 seconds. I think a mic is coming to you. Sorry about that, Matt. Yeah, there you go.
2. Matt Belgard, Chair of the APEC Rare Disease Network, QUT. Kelly, really appreciated what you just shared. Data is such an important factor here, and what you just highlighted is exactly the point. It's no use collecting data if we don't know how to use it and make use of it effectively for the various purposes. So I guess from an APEC context, and certainly I'll talk to this tomorrow, we're going to move from a data collection exercise to a data analytics dimension, which is what the term we use is purposeful application of data. What do we want to do with the data? And then once we choose what we want to do with the data, we can then work backwards. And of course, ultimately, you'll collect data, but that's not our primary goal. And I think you're spot on. If clinicians, if patients themselves don't have the facilities to and the right technologies to actually input the data, we're going to come unstuck as well. So there's so many different dimensions to this, but really, really important.
Great, thank you. Any other comments or questions? Follow up here? Yes, okay, Famita.
So, hi, I'm Famita Gwadri-Sridhar, Pulse InfoFrame. I have a question about policy. In 1997, I was asked to go to South Africa and look at AIDS. And at that time, South Africa didn't want to admit that there was such a thing as HIV/AIDS. And so what you're really raising today, 20 years later, is that there is either not an acceptance or awareness of rare disease. And we heard from Guatemala that spina bifida, is not fully accepted as a rare condition. Could you share with us how you see changing, the perception in a community that has long struggled with awareness of individuals with different conditions?
I think that in terms of the HIV, the first thing was to get a new president, and when that happened, that was an immediate start. But realistically speaking, it has actually been a very big challenge from a patient advocacy point of view in South Africa, in that the HIV pandemic really started what is health activism, and that actually essentially meant banging down doors, burning down buildings. That's essentially what it was. So when we came onto the front, it's taken us 6 years to get them to realize that we're not actually there to hold them, and set them alight, that we're there to have a fruitful conversation. But with that, I think that they have learned some key things in that you cannot ignore critical mass. So it's about rallying that support. And right now, the HIV, if you look at our mortality rates in terms of HIV, we're actually doing really, really well in terms of treatment, etc. But it has taken, the stigma is still there, and it has taken a lot of time. But I do think that the learning point has been that you cannot ignore us forever. And those patients did really, really well to rally that support. So it's almost a good thing sometimes, because we can say we don't want to see another HIV issue come up again.
Okay, so it's a bit of contrast. Yes, Lisa.
So just kind of picking up on that.
2 seconds. Sorry about that. Thanks, Jesus.
Picking up on that, one of the questions I have is, so that's addressing it from a governmental perspective, right? But still going back to the stigma, that's a very individual issue that you are up against, which is a real challenge. So are you working outside the rare disease community to try to bring that in, not just with the hospitals, but church groups and others who can get through to the individuals? Because I feel like you're going to have to come at it from both angles, I'm sure.
I think it's always important to remember we're treating people.
Right.
So it's to, and you've always got to, and that's where the palliative care argument, well, not argument, but discussion is so critical, because they look at it from a holistic point of view, taking into account the patient's well-being, the spiritual aspect as well. So yes, we do. We engage with lots of stakeholders. We realize that we can't solve the problem from our filter alone. But in terms of the stigma, I think just acceptance. And that's one of the most difficult things, I think, for families, because you make yourself vulnerable. And in that vulnerability lies weakness. So you need to make them feel that they're supported enough to be able to go through that initial phase of vulnerability, to be able to get the support they need.
Excellent. Thank you very, very much, Kelly. Really appreciate it. Okay, so we have one more regional presentation here, and this is from Jesus. Where is he? Oh, here you are. And Jesus is also a member of the council, newly elected this year, so we're delighted to actually have him on board. And I think you're going to present to us both in terms of Alibert or just on Alibert?
Yes, Alibert.
Okay, perfect.
Thank you very much for this opportunity to talk about Alianza Iberoamericana, Ibero-American Alliance. We have a few time for this presentation, and you will to be prepared. I tried to explain in 2 hours what happened in Ibero-American Alliance. I wanted to tell you it's a pleasure being here and try to explain what we are. We represented 15 countries in Latin America. We are 52 members and more than 500 patient organizations. That means around 47 million of people in this part of the world. We have in each country very, very large differences and particularities in an economic and cultural, but we try to enforce this. Okay. We try to push together to try to understand what happened in this region, and we have to mention these memberships and collaborations. In the beginning, we try to understand what happened in the region and try to understand and explain what happened with the policies and the culture of the rare disease movement in each country. In the main findings, the patients' organizations are very young, and older other ones are very, very old, working in this issue. We find 316 members with one range of 5,000. Led by affected women or related people with rare disease are 83%. It's very highly because they have a member of the family related with a rare disease. And they have a very, very deep problems with the financial sources and try to get money to develop this work, and problems to get hiring personnel appropriated for develop the work too. The main task of these organizations are provide information and guidance. They with governments and states to promote agreements and that allow to inclusion of people with rare diseases. I'm so sorry. The leaders are aware for training needs and the organization's management for orphan drugs and research and public policies, as well as our patient health professionals too. our priority tasks are advocacy and training of patients as a way for empowerment, training health professionals on rare disease, and map of their rare disease resources in this region too. The request to every one of you have a copy of this statement on positioning of Oliver was signed by Oliver Federer Fadepov, and we talked about this in the past speech with John Lickham. Do you remember? Right? And this position was integrate the policy and referring to access and rationale of use medicines is essential and strategic health technologies. How explain it in the past with Fadepov, right? We have many projects for 2019. In the future, we will do work in a study called In Stereo Latam, where we try to research about in these countries about social health and needs of people with rare diseases in these countries, about from the Ibero-American information and that guidance for services for rare diseases, call it CEO, Service and Information and Orientation. This is a hotline for rare diseases where we try to give information and canalize it to the patients for professionals. They are the main issues to the things that we think are important to develop this project and the inclusion criteria for develop these services. In Stereo Latam, try to research about the population, and we will take a sample around 400 people for each country to try to research in this questionnaire. Will be available in Spanish and Portuguese too. We will research in sociodemographic and data diagnosis and treatment information and these criteria. How you can see that to try to develop this project, we have to avoid these issues too. For the final, there we are. The numbers of beneficiaries, the number of the indirect beneficiaries. This is a big population in this area, in this region too. Brazil have a line to assist patients with rare disease too in this moment. That's why we don't take into account to Brazil. Okay. This project will be developed for these associations and given that your support too. I'm going to left this slide our contact emails for any questions about this presentation. We spent 5 minutes more time expected. Okay, thank you very much for this long day. And your mind is in other place to try to be in, and attend other compromises too right now. It's very difficult to be the last one here.
No, you carried it off very well. Thank you so much, Jesus. And as you can see, we've gone from some very newly formed to to a very, very long-standing association. I think Jesus also indicated this is a really active, vibrant group, and also has roots in terms of the rare disease networks in Spain and Portugal. So I think that's been a huge asset to being able to get Alibert in Latin America to the level that it is, and that continued partnership, I think, has been tremendous in terms of advancing, even with the recognition, as you say.
It's very difficult for the last one try to explain different things with the other people. They say in the same. We are pushing in the same issues too, and the goals are the same for everybody.
Absolutely.
That's why it's very, very difficult to try to be different like the rest of the speeches.
No, you did an excellent job, and I think we recognize that, there are, in fact, really regional benefits in terms of that kind of an alliance. You have a small advantage in the sense that I think, as Kelly said, there's 11 different languages they're working with. In the APARTO region, we're working with, at least a different language for almost every single country. At least you only have Spanish and Portuguese to worry about. You know what I mean? It gives you a huge advantage in terms of working together.
Absolutely. Thank you very much.
And there's a question there. Yes.
Question.
Yes. I don't know if we can we get that last slide back up? Yeah. I don't know. They may have to do it, but we can do that. You want to get a picture of it? Sure. Yeah, we can get a picture of it. Yes, question there.
Actually, I'm talking about Institute Rare Lives in Brazil. I would like to speak about the rare line that we have in Brazil, because Alibert is launching SIO, and we would like to let you know about this rare line together with the city of São Paulo, and it's an 800 number, and all over Brazil can call this number and have access directly with physicians, technicians, and if we don't know, we tell them that we're going to try to find out about the disease.
That is the main reason, because Alibert tried to launch this CO in Spanish for the rest of the people.
I just wanted to mention that Brazil is a pioneer with the rare lines, and it's a partnership with Portugal as well.
We try to develop investigation, research, understanding the area, and follow the good the good practices too. This is the main sense of this alliance.
Yes, thank you very much. I think it's really good. And hopefully we'll find some ways, through RDI as well, to be able to have specific, regional portals that actually will have that information. We were talking about it yesterday at the RDI meeting. We need to be a resource on the RDI website as well, where different countries, national alliances, and certainly regional alliances can also be able to present information. We're also talking about hopefully having the opportunity or the capacity to present some of those resources in different languages. So I think we're looking into the future, so things like your helpline as well could also be promoted there. So really appreciate it in terms of what you're bringing forth and looking forward. I mean, obviously we are hoping that we will get the active support and participation of the different alliances in terms of bringing that information forth, but also helping to make it available on an ongoing basis. So really appreciate what you're saying. I mean, it's been a very fast trip for RDI to get to where we are now. So I think none of us feel like we're at a point where we can say, okay, this is it, this is what's set up, and here's how we're going. But I think it's been a huge asset, and especially as Jesus is presenting here in terms of Alibert, it's been an example of a really important alliance. And again, with Eurotas having given, some support in terms of the establishment of RDI and really carrying it, I think Alibert, with its origins in Spain and Portugal, have done a tremendous service in terms of being able to reach across to actually help foster the development in Latin America in a way that would not have probably been as fast without the kind of ongoing support. So we really, I think, look for those kinds of collaborations.
Thank you.
Yeah. Thank you very, very much.
Thank you very much.
And this actually does bring us to the end of a very long day. For some of us who started with the AGM and, actually had a whirlwind presentation in terms of RDI for 2018 and 2019, and definitely in terms of the Global Commission and now ongoing. Jan, did you want to make a comment here?
Yes.
Yes. I don't know if we have a mic.
Logistic comments.
We need a microphone somewhere.
Because I'm getting too worried for the reception this evening.
Yes.
So we have.
Do
Sorry,
you want a mic?
Just
I share mine, but it's kind of attached to my back.
Yeah.
Yeah. Go ahead.
No, it works. Yeah.
Okay.
So logistics for tonight. I'm just a bit worried because we have this reception at the residence of the ambassador of Spain. Now, it's snowy outside, so that means that we have some participants which are prevented to come. And I can guess that you are exhausted after a long day, so some of you may just want to go back to the hotel and skip it, which I perfectly respect and understand. Now, my problem is that it's difficult to obtain to go to the residence of an ambassador for a small NGO group, ignored as we are. So we've been able to do it thanks to some members, particularly FEDER. And I like to make sure that we have a good group going, particularly that we know that the ambassador of Spain is sick today, so he was not at the office and he cannot come, although it's his home. So he will be in bed upstairs, I don't know where, in the attic. In El Ático, but there is 5 other ambassadors coming, as far as we know, who have confirmed this afternoon. So I just want to make sure that we give a good impression and that you also take advantage to reach out to them, even if they are not from your country, but just to try to brainwash them about rare disease. So, okay? Great, thank you. That's all.
So thank you. Yeah, I mean, and everybody here is definitely invited. If you don't have the exact address, I mean, it is available there. I really echo Jan. This is such an important opportunity for us. To have somebody open their home as an ambassador is a unique opportunity. Last year, when we had the forum for the NGOs in 2016, we actually had a reception at the Belgian consulate, but this is totally different. It's at a different level. And we really want to demonstrate how very, very pleased we are in terms of having that level of support. And it really is a great signal. So obviously, as Jan says, it's not to pressure anybody who, isn't able or not feeling up to going. But really, if you can, it would be such a wonderful opportunity to be able to. Oh, if you come, you must bring your ID in order to get in. And if you come, you don't have to stay for the entire 2 hours. You can actually drink heavily, eat, and then go. At 8, it's finished anyway. Okay, we'll be done by 8. So really, we look forward to seeing you there. Thank you very much. And thanks very much to FEDER for having made that possible. Thank you all for an amazing day. It's been long. It's been packed. If you remember anything out of it, you're amazing, because I absolutely remember nothing of what was taking place here. But thank you very much. And we're hoping to look forward to those of you who are coming tomorrow. Thank you again.